speakers or talk to people in the room to get that answered. Okay, so that's all I wanted to say about the as an introduction. Welcome everybody. The first panel, I think I'm still vaguely on time, aren't I? So the first panel, which I'm going to be chairing, in fact, I think I'm probably chairing both of them, aren't I? Is that right? Both times. So the first panel is about using data to improve healthcare in rheumatology and orthopaedics. And our first speaker is Celia Gregson, who's a professor in clinical epidemiology from the University of Bristol, one of my universities. So it's really great to welcome a colleague from a previous appointment. So Celia is the Professor of Clinical Epidemiology and an NIH Global Health Research Professor of Healthy Aging in Sub-Saharan Africa. That's a great title. In the UK, Celia's research identified persistent and growing health inequalities in hip fracture incidence and outcomes. So her work on the REDUCE study addresses unwarranted variation in the delivery of hip fracture services in England and Wales, leading to a launch of the REDUCE study hip fracture implementation toolkit in 2023. And she's going to be talking to us about that work. So welcome, Celia. I hope we have Celia with us.
Yeah, I'm here.
So welcome. If you've got a presentation to share, would you?
I have.
Please start.
Or control the slides from here. It'll be easier for you.
I'm sure. So first of all, good morning, everybody. Can you hear me?
Yes.
Okay, super. And can you see my slides that I'm sharing with you?
Yes, but but I think there's a screen over it as well. Is that me?
Oh no.
Yeah, you shared
No,
this over.
it's fine now. It's cleared.
Yeah.
Yeah.
Okay. Can I ask in the room? Can you hear and see all right?
Yeah. Yes, we can.
Okay, super. Thank you very much. All right, then I'll make a start. So thanks very much for the invitation to speak. It's great to be here. What I'm going to present is entirely Versus Arthritis funded. And this project's been going on really for the last 3 years through the pandemic, and yet here we are. So many thanks to the names on this slide, who are the REDUCE study team. And I'm going to tell you about patient recovery after hip fracture and how that is associated with multiple modifiable components of hospital service delivery in England and Wales. And this study is called the REDUCE study. So the backdrop to all of this is that we know that there is huge variation across the country in terms of how hip fracture care is delivered. And here you can see a caterpillar plot where each vertical line is a hospital. And you can see the proportion of patients getting prompt hip fracture surgery across all of the different 176 hospitals, 172 hospitals in England and Wales. And in one end of the spectrum, you've got 24% of patients getting prompt theatre surgery, and then at the other end, 94%. So hip fracture requires complex multidisciplinary care. It tests our organisational structures within each of our hospitals. And despite lots of standards and guidelines over the year, there remains this amount of variation across a number of parameters in terms of hip fracture care. So the study aimed to determine which hospital level organisational factors predict adverse outcomes for hip fracture patients in the post-injury period, taking into account patient case mix, and then to use those findings to inform the development of an implementation toolkit, a set of tools aimed at improving national hip fracture service delivery. So what we did was we took lots of data and we linked them together. So this is a hip fracture cohort study across England and Wales. We took HES data for England for a 3-year period, contemporaneous PEDU data for Wales. We linked both of those to the National Hip Fracture Database, and we identified overall 178,000 patients who had successfully linked data for an index hip fracture. And then at the same time, we wanted to identify metrics of organisational activity across the 172 hospitals. So we were able to source 18 national audits and service data sets for the same 3-year period, and we extracted from those 231 organisational factors that said something about how hospitals were delivering care. And then we linked that all together in a multi-level data set. And then we use multi-level models to look at the exposure, so hospital level organizational factors, 231 of those across the 172 hospitals, and how they related to the outcomes. And we had 9 patient level outcomes. And we were able to adjust these multi-level models for patient case mix, as you see there. So you can see we have 9 outcomes. I'm not going through all of those today, but suffice to say that there have been quite a lot of analyses. But for the purposes of what I'm talking about here, I'm interested in the organizational factors that were independently associated with at least one patient outcome, and that were associated with either a bed day saving or a cost saving over 1 year, that weren't associated with adverse patient outcomes, and that were things that were potentially modifiable in terms of how organizations deliver hip fracture care. So here's the data set that we were interrogating, 178,000 patients across 172 hospitals. You can see the majority were in England, 94%. 23% of patients were aged 90 years or older. The majority were female. Most came in from their own home or sheltered housing at the time that they broke their hip. And 37% were freely mobile without a walking aid prior to their hip fracture. So in terms of the 9 patient outcomes, all listed here, you can see that there's a lot of variability. Now, so honing in first of all on length of stay. So this is a super spell length of stay. So the acute plus rehab NHS total period in hospital. And on average, mean, people were staying 3 weeks in hospital. But you can see the data are skewed, the SD is 20. And some hospitals, patients stayed on average 12 days, and in other hospitals, patients stayed on average 42 days. So a lot of variation in length of stay between hospitals. Then we have 30-day mortality. So overall, national 30-day mortality was 7.3%, but some hospitals had a 30-day mortality on average 3.7% and others 10.4%. Looking down at the bottom here, you can see that we wanted to know how much time patients were spending in hospital in the year after their hip fracture. And you can see on average, people spent about a month in hospital. Some of that obviously was, or most of it was actually the initial super spell. But some hospitals had their patients staying approximately on average 20 days in the year, and others 54. And that obviously translated to variation in health costs over that year. So we worked with health economists to calculate the costs of in-hospital care, direct health costs in the year post-hip fracture. And across the country, hospitals spend on average about £14,500 per patient in that year. But some hospitals were only spending just shy of £11,000 per patient on average, whereas other hospitals were spending more than double that. So huge variation in how much hospitals are spending on their hip fracture population. And you can see also 1 year mortality is high at 28%, and that was also variable between hospitals. So overall, we found 13 potentially modifiable organisational factors independently associated with either a cost or a bed day saving, plus or minus other positive patient outcomes. So the headline finding was the provision of weekend physiotherapy. So those hospitals providing physiotherapy to their hip fracture population at the weekend saw on average a cost saving per patient of £676 in the year post hip fracture. They also saw a bed day saving of 2.3 days per patient. You can see that across all of these variables, there is a cost saving associated with, for example, hospitals that are providing orthogeriatrician assessment to all of their patients within 72 hours of admission. They also saw lower annual mortality. Hospitals where there was a consultant orthogeriatrician attending monthly clinical governance meetings, they saw a cost saving and a bed day saving. Hospitals where a higher proportion of patients were admitted to a orthopedic ward within 4 hours of presenting to the emergency department, cost saving. Prompt post-operative mobilization of more than 70% of the caseload, so that's the day of surgery or the day after surgery. Then those hospitals saw on average a cost saving and a bed day saving. Inpatient delirium assessment, so those hospitals that were routinely assessing for delirium saw a cost saving and also a higher proportion of patients getting home. Lower levels of delirium when they actually test for delirium also was associated independently with a cost saving and a bed day saving. And hospitals that were providing bone health assessment during admission to all of their patients, again, a cost saving. And then in terms of additional bed day savings, we saw that those hospitals that had dedicated hip fracture wards, that had fracture liaison services in place, that regularly disseminated National Hip Fracture Database audit data to their hip fracture ward staff so they felt part of that process and team. Hospitals that provided nerve blocks preoperatively, often in the emergency department, to their hip fracture population, and hospitals where there was a higher use of total hip replacements, they also saw bed day savings. We identified a further 33 organisational factors associated with one or more of the overall 9 patient outcomes. So quite a lot of organisational factors came out of these models as being relevant to these patient outcomes. Now, clearly, there are strengths to what I've presented. It's a really large, uniquely nationally data-linked data set over a 3-year period with extensive organisational data. But you can identify with such large sample sizes non-clinically meaningful associations because the sample size is so big. Causality can't be inferred. These are an ecological analysis, and some of the parameters I've presented are probably markers of good service rather than necessarily causal of patient outcome. And data are likely to be non-randomly missing in that those hospitals who are poorer performing are more likely to have more missing data. That all said, we've taken those data that I've presented together with a qualitative study, which I haven't had time to go into, and that's fed into the development of content of a series of different tools that are now freely available that make up this reduced toolkit. And that includes a cost calculator. So the health economic data fed into this cost calculator. So each hospital in England and Wales can go on this, download this tool, look up its how much it's spending per year. So our hospital spends, I think, what is it, £8 million per year on hip fractures. So you can look up how much your hospital is spending on hip fractures and how much it could potentially save by introducing those different factors that I've just presented to you. And it also leads into the development of a business case for a service improvement. So this is the website. If you scan the QR code, it'll take you straight to this website, and then you can click on the different domains and download the different tools that you can use, and they're all freely available. So to conclude, patient outcomes and care costs post-hip fracture vary substantially between hospitals. We've certainly seen that. We've identified multiple differences in how hospitals deliver hip fracture care that are associated with patient outcomes and that are potentially modifiable. And this new freely available reduced study toolkit provides multiple practical approaches for hip fracture service improvement, designed for use by service managers and clinical leads in order to modify their current hip fracture care delivery and service. The other point to make, I think, particularly for this audience, is that the methodology that we've used here, that we've applied to hip fracture, is potentially applicable to other complex healthcare pathways where national clinical audit data are accessible. And I have begun conversations, for example, with NELA, the laparotomy audit. But I think that there are others in the room that may have access to data such as this, where these methods could be applied. And with that, I would like to thank the Reduce Study team, clearly the funding by Versus Arthritis, and also the collaboration with the Royal Osteoporosis Society, who will house this toolkit beyond the term of the grant funding from Versus Arthritis. So thank you for that. And I'll finish there, I think.
Thank you, Celia. That's great. Yes. We would like to hold the questions to the end. Is that okay?
Yes, that's fine.
Thank you very much.
Thanks.
Okay, make a note of any questions and we'll come back. Okay, thank you. So our next speaker is Michael Parker. Hi, sorry, welcome. I take it you've got slides already loaded on the. Okay, so I shall give you a brief introduction. So Michael is a research officer at the University of Swansea. I hope you didn't have to do difficult a journey this morning. So Michael is also a data scientist who works for the National Centre for Population Health and Wellbeing Research and the Swansea Data Lab. He's worked with data in the SAIL data bank on a range of projects looking at child health, service utilisation, COVID-19 and rheumatic disorders. And today he's providing an update on the RUMAP study. And we'll talk about the geographical inequalities and the effects on people with rheumatic disorders. Thank you very much, Michael.
I'd just like to open by thanking all the collaborators and people who contributed to the work, particularly the bit of animation, how we've enabled this work to go forward. So, quick background and aims. So, as we're all very aware, when we're planning services, it's important to know who we're planning services for, where they are, and their general characteristics, but also what services they don't currently have available to them. And in relation to distance and travel time, there's quite a decent basis of research on the negative outcomes associated with being far away from the services you require. So this is particularly well studied in cancer. However, it's not particularly well studied in rheumatic conditions. And they're also not specific to rheumatic conditions, but there's a lot of limitations to do with distance and travel time in how they're defined. So many studies might define distance as, say, as the crow flies, rather than specifically how long it might take or how far the actual real distance might be from door to door, from your house to a particular service. And naturally, on top of distance and travel time, there are a number of factors that might contribute to make it difficult to attend an appointment. For example, the cost associated with travel, also transport, accessibility, perceptions, and also, quite importantly, perceptions and expectations of care that you're going to receive. And naturally, if you had multiple of these conditions or multiple of these issues, these would have compounding effects and might make it even more difficult to attend your appointments. So with that vein,
Michael, sorry to interrupt. Would you mind using the microphone?
of course, it is. I'll try to step you off. So, can you all hear me now? Is that better? So naturally, this work is going to specifically look at the effect of travel time on healthcare use for people with inflammatory arthritis at a population level in Wales. So a quick bit on how this was done. All of this work was carried out within the SAIL data bank. For any of you who are familiar with the SAIL data bank, it contains billions of records of personal level data, primary care, secondary care data, and it's all linked. So we can follow a person from the moment they're born to the moment they die, in some cases also to the moment of an outcome. And it's really, really useful. It's all online, all safe to use. So the inclusion criteria for this was a valid inflammatory arthritis code, diagnosis code, and we recruited between 2005 and just prior to the COVID pandemic in 2020. For confirmation, we required that they had at least 2 relevant disease-modifying anti-rheumatic drugs, and also that they had substantial, sufficient demographic information such as age, sex, and importantly, the location that they lived at the time of the diagnosis, because that's critical for this work. This work utilised primary and secondary care data in some aspects. We've also included comorbidities, we've incorporated the electronic frailty index and prescription data. And quite importantly, I just wanted to specify how the travel time was defined in this work, because I highlighted the issues in some other studies with how it's been defined. So in this work, travel time has been defined for both car and by bus, and for when it's been done by bus, the number of stops have also been provided. And the way it's been defined is it's been calculated between the address of an individual to the nearest rheumatology service, and then to allow for anonymity, it's been averaged out the lower super output area that they live in. And for anybody who isn't familiar with the lower super output area, it's a geographical unit that's essentially slightly higher than a postcode. So an LSOA contains about 650 addresses. So the travel time is the average from that LSOA for everybody in that LSOA to the nearest rheumatology service in Wales.
Just let me turn this down a minute.
So just to provide you some the people that we study and the cohort characteristics. In green, we have the number of individuals with rheumatoid arthritis. That's at about 80% of the individuals in the cohort. We have about 18.6% with psoriatic arthritis and 2.5% with axial spondyloarthritis. The gender split is people with rheumatoid arthritis for about 68% female. With psoriatic arthritis, it was slightly more balanced, about 50% female, and then with axial spondyloarthritis with a male dominated cohort, and who had about 68% of them were male. For the age distribution, rheumatoid arthritis people generally slightly older, with over 50% of them being over the age of 60. People with psoriatic arthritis were slightly younger than that. Between the majority of them between the age of 40 and 60, and then people with axial spondyloarthritis were slightly younger than that, with the average age of the majority of them being between the ages of 30 and 50. Also, just to give you an idea about the health status of the cohort. So these cohorts were taken at baseline, and individuals with rheumatoid arthritis, about 75% of them had at least one other comorbidity on top of their rheumatoid arthritis at the point of diagnosis or when their first code appeared in the data set. With 25% of them having 3 or more comorbidities. So generally, potentially quite an unwell set of individuals. For psoriatic and axial spondyloarthritis, this went down, but this might be able to speak to a function of age, as the people with rheumatoid arthritis were older and had more time to accrue for the comorbidities. So just to give you an idea about how the travel time is distributed, in the red we have the travel time by car, and as you would expect, the majority have access to a rheumatology service within a very short amount of time. So most people access within 25 minutes. However, there is a subset of people who fail to have access within an hour, and that's about 10% of individuals have a travel time greater than an hour in Wales to the nearest rheumatology service. As you would expect with bus, it's more right skewed, so the average travel time is probably about 40 minutes, but there are some individuals who have a travel time of up to 2 hours, which is a substantially long time, including changes. However, this isn't the entire story, because there are a further set of individuals who have no access at all. So this graph in purple doesn't represent those individuals, and in fact, about 12% of individuals don't have any access to a rheumatology service by bus, or don't have access within 2 hours. So as you can see, we're sort of building an idea of a cohort here who potentially, if they did have a car, might be substantially unwell and may not have bus access, and if they don't have any form of support network, may find it very, very difficult to access a rheumatology service. Just to sort of give you an idea about how this is situated geographically, we have about 9% of the cohort who have a travel time by car of over 60 minutes, and all of these people in Wales come from 3 health boards. So 2% of them come from the Betsy Cadwell Health Board, which is the majority of North Wales. 80% of them come from the Hywel Health Board, which is southwest, and yet the southwest and sort of middle of Wales, and then 10% or just shy of 12% come from Powys, all very rural health boards. So looking at these individuals after their initial diagnosis, or when the first instance of an inflammatory arthritis code appears in their records, we find that 12% of people have no record of a rheumatology outpatient appointment within 1 year within the SAIL data. So quite a substantial amount of people. Looking forward to 4 to 5 years, accounting for the individuals who died, around 22% of them now are not accessing or have no record of a rheumatology outpatient appointment. If you stratify this by travel time, you find that individuals who live over an hour away have substantially fewer records than individuals who live within an hour. For 0 to 1 year, individuals who live over an hour away have around a 20% no records versus 10% for those who live within the hour. So it's so seriously suggesting that time is a factor contributing to the failure to have these outpatient appointments. So further, we looked at this regression to to prove its significance. And these odds ratios are for time being greater than 60 minutes. And the dependent variable is having any episodes or having any record of appointment. And for this, we've adjusted for age, sex, deprivation, comorbidities, and frailty. And as you might be able to see, you have an odds ratio of 0.48 if you live over an hour away for rheumatology outpatient appointments, suggesting that you are half as likely to have a rheumatology outpatient appointment if you live over an hour away compared to those who live within the hour. Conversely, you have 1.5 times the odds of having an elective admission and 1.3 times the odds of having a GP appointment. These trends follow on to 4 to 5 years. So an odds ratio of 0.63 for rheumatology outpatient appointments, so you're still less likely at 5 years to have an outpatient appointment. You're 2.1 times more likely to have an elective admission, and then GP event days, the statistical significance falls off at that point. So just to briefly discuss, we've identified a population cohort of individuals with inflammatory arthritis using validated recodes, and their demographic, sex, age resemble what we would expect of individuals with inflammatory arthritis. There's certainly an indication that travel time is an important factor that is modulating the decision to access care. And this is after we've adjusted for various socio-demographic and clinical factors. So there's definite opportunity here and further work to explore travel time in relation to other clinical events such as opioid and steroid use. But also I want to highlight that there is other ongoing qualitative work that explores the interactions, the important interactions that go into this, because this isn't just an effect of travel time. The perception and expectations is an important aspect of why there is a failure to attend care or a failure to have any record of care. So there is ongoing work to address that. I'd like to acknowledge everybody involved in the team, particularly those involved in developing the time data, as it was very complicated and it's an incredible data set to be able to work with. My references, thank you very much.
Thank you. It's really fascinating. I'm sure there are going to be lots of questions at the end of this. We're going to be pushed to keep it to 20 minutes. There's lots more discussion, I think, during the tea break as well. So next speaker is Alan Silman. Welcome, Alan, who's going to be talking to us about supporting older people to make informed decisions about knee surgery. I am going to give you a little bit of your background. So Alan's an epidemiologist and a rheumatologist. He was the director of UK's Arthritis Research Epidemiology Unit in Manchester, then became Arthritis Research UK's first medical director, and in this role was responsible for the strategic direction of the charities research activities. Currently, he's the Professor of Musculoskeletal Health at Oxford University. His research interests are mainly in the field of comorbidities and their relation to healthcare and healthcare outcomes, and the use of big data, in inverted commas, to address these issues. So, welcome, Alan, and I'll hand over to you now.
This is very much going to be a small data presentation and my foray into qualitative side. So I'm feeling slightly nervous given my background. These are data of the age of primary knee replacement from the National Joint Register, published in this year for last year. And as you can see, the majority of people having knee replacement surgery in this country are aged over 70, and with a substantial proportion aged over 80. And that age is increasing. Why does this matter? Well, it matters because with increasing age is the increasing accumulation of morbidities at other sites. These are typical data, and as you can see, we get older, then we accumulate illnesses. And later on in this brief talk, we'll talk about what is an appropriate or inappropriate way to actually assess the level of increasing morbidity with age. So why the concern about pre-existing morbidity in relation to elderly people coming to knee surgery? Well, if you speak to surgeons, their main concern is risk. their main concern is anaesthetic risk and operative risk. But there needs to be, and I guess this is why I want the emphasis on this talk today, about the issues of the accumulated morbidity on the outcomes, and that often in a surgical perspective is rarely understood. So what are the safety issues, the discussions that orthopedic surgeons, that primary care physicians have with their elderly patients with multiple concerns? They talk about the perioperative risk, the risk during surgery, the risk of a cardiovascular or a pulmonary event, of bleeding. Orthopedic surgeons also worry about the difficulty in doing surgery, for example, in somebody who is substantially obese or has got other problems that are going to make the surgery technically difficult, might make wound stitching also difficult. And then the concern about the post-operative complications, particularly wound healing, thromboembolic phenomenon, and sepsis. So the surgical argument about the influence of comorbidity is focused on safety. On the other side of the coin, I think we need to think about three other areas that are important. Do individuals who are coming up for knee surgery have other morbidities? Is the benefit that they could get from their surgery constrained? Would they get more benefit if they didn't have those comorbidities? Secondly, if they have that surgery, is it going to make their existing health problems worse? And thirdly, as we found that there are often social factors, for example, the care and family issues. So, for example, this is one of the patients in our study, a woman aged 78. She had chronic obstructive pulmonary disease, mild cognitive decline, glaucoma, and a care for her husband. And the things that affected her was that the COPD limited her exercise tolerance. And therefore, improving her functional ability in her knees is not going to make it any easier for her to go upstairs. She had mild cognitive decline. Was the anaesthesia likely to exacerbate that? It was interesting to hear Celia talking about post-operative delirium following femoral neck fracture. And my own mother had that, so I'm quite sensitive to that as a complication. And also this lady cared for her husband, and she was concerned about what was going to happen post-operatively. So when we think about the issues related to people like that who have surgery, do they have an increase in risk or a decrease in benefit? Now, we came to this in studies on the hip fracture. These are two studies, and great to see George here in the audience today. This was a big data study using a GPRD, and we asked the question about does pre-existing morbidity influence the risks and benefits from total hip replacement, and we took patients and linked between CPRD and HES and other data sets. We looked at a number of outcomes. We looked at functional outcomes, like in this case, like the Oxford Hip Score, which is a score that goes between 0 and 48, and 48 is, if you like, a perfect outcome, and the lowest score is poorer. We used a number of measures of morbidity. This was the number of chronic disorders. And as you can see in the blue bars, it shows the level of the Oxford Hip Score pre-operative. And in all groups, the scores were quite low, lower in those who had more than 3 morbidities. The important thing was that in all groups, there was a change to the better. Independent of how many morbidities, the change in Oxford Hip Score was very similar. We can look at morbidity in a number of other ways. We looked at the number of prescribed drugs. And as you can see, independent of whether you had very little medication indicating very little background morbidity, or you had taking 13 medications, phenomenal, I know, and you're still getting an improvement. We looked at a whole range of other factors, and generally we found that pre-existing morbidity, however you measured it, did not constrain the benefit from surgery. I haven't got time to show. We also found actually that the risks from surgery in those with multimorbidity were relatively small, affecting a small number of people. So given the fact that surgery should be open to everybody with multimorbidity, what did we find in terms who actually had surgery? So we looked at people who came to GP land with a diagnosis of osteoarthritis, and we looked how their pre-existing morbidity influenced their likelihood of having surgery. And again, in brief, to say that in contrast to pre-morbidity not adversely affecting the outcomes, the number of morbidities did influence the likelihood you were having surgery. So there's a dissonance there, that in some way the decision-making process to have surgery for people with multimorbidities doesn't seem to take account of the relatively lack of importance, if I may, on the outcomes. Now, those were data from hips. We were concerned mainly to focus on knee replacement because the orthopedic surgeons with whom I work with say what I think is a fairly well-known fact, that people with knee replacement tend to do worse than people with hip replacement. These are some data about patient satisfaction along a number of different functional outcomes. And as you can see, sorry, the colour's not very good, but to the left, the darker grey bars indicate people who are very dissatisfied, and the two lighter bars to the right in each one, people who are satisfied or very satisfied across a whole range of functional outcomes. And I think that tells us actually there's not a single outcome in knee surgery. But I think in general, possibly only about 75% of patients are really satisfied. And we know also from the NJR data that actually a number of people coming to knee surgery do have what is quoted as severe systemic disease. So here we have the issue that patients are coming to surgery, they're elderly, they have morbidities. The data might show that they may improve, but there are concerns. So how are we going to make those judgments? And importantly, all the data that we were looking at in terms of morbidity, counts of diseases, number of prescriptions, number of visits to the GP, are not what the patient believes is their health status. So we started a study funded by Oliver Bird, looking at what patients would need to make an informed decision about knee replacement surgery in the face of multimorbidity. And we did that, and I did that with colleagues in quantitative science and part of primary healthcare sciences in Oxford, and for NHS Trust. And we had two main questions. How does an individual's perception of their existing health status influence their decision for knee replacement surgery? So we weren't interested in, if you like, how many diseases or prescription. In terms of what they were feeling at the time, how much did that influence their surgery? And secondly, did that make a difference to their outcome? If you felt that your pre-existing problems were so great, would that make an effect on how you felt post-surgery? And this could work in two directions. It's not obvious which direction. It could be that you felt my other problems, my respiratory disease, my eye problems, etc., were overwhelming. But actually, when you have the surgery, the relief in pain actually means that your concerns were less apparent, or the converse. So this is what we did. So we set up a study. We identified patients at the time that the GPs referred them to orthopedic departments. The letters were scanned by juniors within the orthopaedic department, identifying people that the GP had indicated had comorbidities, aged over 70. And we interviewed them at the time before their orthopaedic, before their consultation. And then we interviewed those who had surgery 6 months after surgery. For those that didn't have surgery, the plan was to interview them after their orthopaedic appointment. Now, we had two challenges. The first is this was based on a naive assumption that we knew the pathways by which people following GP came to orthopaedic surgery. And when the lead researcher was reporting that both a number of patients didn't know how they got to the orthopaedic surgeon, what was the route? Well, I brightly turned up and said, why don't we do a mini mental state on examination? Because probably they've got some cognitive decline. And then the orthopaedic surgeon said to me, he said, Alan, he said, I can't tell you the pathway by which patients come to us. So that was an issue in doing this kind of study. And the reason why it's important, because there's often filtering at different levels. There may be in a consultation with a GP, there may be in consultation at a tier 2 service or with a physiotherapist. So the way the decision's made depends on the pathway. The second challenge we had was COVID hit when we decided to start this, and suddenly the referrals plummeted. One of our centres we were going to recruit from, they had to withdraw, and this orthopaedic surgeon, who was quite a few years younger than me, said that when referrals came back after the end of the pandemic, he said, if I took, he was thinking 59, he said, if I didn't take any more patients on my waiting list, I'd have more than enough work for retirement, and therefore I'm not going to be able to help the study. And we do know that waiting times increased. This is a recent survey of NHS Trust, the average waiting time for total knee replacement, on average over a year. And indeed, in a number, it's over 80 weeks. This kind of altered the way we've done the study, because we've had patients who came in, were agreed to surgery, but with 6 months' time, they still haven't had surgery. So actually now we've got patients, we've had their preoperative interviews, we've had their interview to see how they may have changed having been on a waiting list, which actually, if you like, is a natural experiment that we're aiming to undertake, and we can also aim to see what's happened. The data are now all in and are being analysed by my primary care colleagues, with 43 patients recruited, a mean age of 76. 40 of them have been followed up, and the qualitative scientists in our group assure us that this is more than adequate to identify the themes that are important. And one of the key outputs from this study is the interviews are being recorded and will be uploaded to Health Talk online. And I know that people in the charity were aware of this, which will be a resource for helping people with these complex problems understand how they should make a decision in the face of epidemiological evidence, which seems to be pointing in different ways. Thank you.
Thank you very much. So our last speakers this morning, there are 2 speakers, well, yes. Yes, so I've got long introductions to make, so we've got 2 speakers for our last talk of the morning. So first is Will Dixon. Welcome, Will. He's the Professor of Digital Epidemiology at the University of Manchester and a co-presenter, yes. And my apologies if I don't pronounce your name correctly, Bieler, yes? Who's a research associate working at the University of Manchester, I assume with you. So Will is, as I said, the Professor of Digital Epidemiology and a consultant rheumatologist at Salford Royal Hospital. Will chairs the Scientific Advisory Board for Our Future Health and is a member of the MRC's Population and Systems Medicine Board and the Population Health Sciences Group. His research aims to address clinically important questions by analysing data from patient populations with a particular focus on digital health data. This includes the analysis of electronic health record data from GP surgeries and from hospitals, and the collection and analysis of data direct from patients using smartphones and wearables. And I'm really pleased that Bila is able to join us as well. So Bila is a statistician and a postdoctoral researcher at the Centre of Epidemiology. It's always nice to be able to welcome our early career researchers to come along and present at events like this. He obtained his PhD in statistics from Hasselt University in Belgium and his MSc in biostatistics from Jimma University in Ethiopia. He specialises in Bayesian and computational statistics, focusing on building flexible statistical models, including multi-level hierarchical models and complex time-to-event models. So welcome to you both. I'll hand over to you.
So thanks, Lucy, and thanks for the invitation to come speak. And as in the introduction to the session, this work's funded by the Oliver Bird Fund, administered through the Nuffield Foundation and co-funded by Versus Arthritis. So we all know, and we've heard already this morning, that health data is collected primarily to support clinical care, but there are additional opportunities that that same data can support health research and other purposes. But there are some limitations that come from the availability and the quality of that data. And musculoskeletal or arthritis research really exemplifies many of the health data problems. So the third problem is that the data that you would like to have is missing, it's absent. And if it's not there, you can't analyse it. The second problem is that the data are sometimes inaccurate. So the codes that you might have in primary care records may not reflect the diagnosis that, say, a hospital doctor would give to that patient. The third problem is really significant in rheumatology, is that much of the data that we have is unstructured. So although we've heard about hospital data this morning, that hospital data is often hospital episode statistics about whether people have been inpatients, the diagnoses that they've had as inpatients. But outpatient data is limited to whether somebody has had a visit and to which specialty. It doesn't tell us anything about the diagnoses, so we don't know anything about the case mix in rheumatology services across the country. It doesn't tell us anything about the outcomes of those patients and the treatments that they receive. And the fourth problem is of siloed data, where the data ingredients that you need to do exist and are out there, but they're not joined together. So if you wanted to understand how commonly patients with arthritis receive social care, you have a health data set that tells you what health conditions they've got, but includes no social care data, or you have a social care data set that includes what social services people have had, but it doesn't know what health conditions they've got. So our research programme, in a similar way to the one that you'll hear from George later on, came in response to a call for a local data integration pilot to try and solve some of these problems. So our three aims really were to pilot novel data collection, extraction and integration in rheumatology, done not just for the sake of it, but so that we could answer clinically important research questions about the burden of disease, about identifying as yet undiagnosed disease, and about medication use, all of which we designed so that we could maintain public trust whilst doing so and reusing routinely collected data, and designed for sustainability and scalability beyond this pilot. So the data sources that we're thinking about are routinely collected data in primary care electronic health records, which we've heard a little about already, the CPRD analyses. We're taking the unstructured data from outpatient letters and processing that. We're looking at inpatient electronic health records, and whilst I'm not going to talk at length about that, we are in fact looking at delirium postoperatively through inpatient EHR data in response to certain medications, including opioids. We've collected data directly from patients via web-based surveys. We're looking to link to social care data, and we've also done qualitative research around all of this. I can't talk you through everything that we're doing in the programme, so I'm going to focus on a couple of examples. So the clinical question of those three that I introduced is about the prevalence of disease, how commonly disease happens. I'm going to illustrate that through two different data sources, so through primary care electronic health records and through hospital outpatient letters. And then I'll just touch briefly on the public trust part at the end, because that's so important, and how we've gone about notifying the public of what we've been doing. So, Michael, I need to thank you for illustrating my first point here, that the first line of a funding bid or policy work always says that this disease is this common, and that was indeed the first line of your presentation. So it might say psoriatic arthritis affects 1 in 300 people. But you need that data to be up to date and accurate. Well, how do we understand how commonly diseases happen? Well, in epidemiology, you measure the prevalence by counting how many people have the disease and dividing it by the number of people in the population who might have that disease. And it's possible to do this with electronic health record data from primary care. And here at the bottom, you can see a publication that came from the group in Heal doing exactly this for a range of different inflammatory arthritis. So we tried to replicate that in Salford using primary care data. So we counted how many people had a primary care code for psoriatic arthritis, and we measured how many people had were in the population of Salford, and we calculated the prevalence. And this is the same methodology they would have followed in the Keele paper. But there's a problem in that not everyone who has a GP code for psoriatic arthritis indeed has the disease. And not everyone who has the disease has a code within the GP record. And that's what we wanted to try and explore, looking at both the issue of inaccurate data and siloed data, because often these two data sources aren't linked. So in primary care data, the reason that people analyze this data source readily is because GPs code in real time. So if you go and see your GP, by the time you've left the room, you've already got the code for psoriatic arthritis there in the data set, and that data has been made readily available for research through programs like CPRD. In hospital, if you come and see me in a rheumatology clinic, I'll dictate a letter, it'll get typed up and become an electronic Word document. And that's free text that is useful for direct care when I or the GP or the patient reads that letter, but it's not machine readable. And therefore, we can't count how many people have psoriatic arthritis across the population of people who might come to the rheumatology outpatient clinic. So in order to join together these data sources and look at the match, we have to pre-process this outpatient data. And we can do that using natural language processing or text mining. And so on the left-hand side of the screen, you can see a typical structure for an outpatient letter. So it's semi-structured. It says the reason for attendance, the medications that you're on, and then it goes into the general assessment. But because there's some structure to it, the diagnoses are listed, we can then pull out that bit of information. We can identify what are diagnoses versus what are procedures, and then we can map those diagnoses to codes that allow us to look for certain codes that make up a code list for a particular condition. So if we want the computer to learn how to do that, we have to evaluate, we have to train it to do it, and then we have to evaluate how well it performs. But rather than seeing whether it works perfectly or not, you have to recognize, first of all, that if you have two different humans annotating the data, they will also not always get it exactly the same way. So we have had outpatient letters. We've given it to two different humans and said, please code this data. And when you compare human versus human, you get an exact match about 80% of the time. And then they're pretty close 9 out of 10 times, but it's not always perfect. If you then train the computer to do it and you compare how well does the computer do versus the gold standard of the agreement between the two humans, we find that the automated coding performs nearly as well as the humans, and therefore it's sort of as good as we can expect to then pass all of this data through the computer to generate codes and to help address our question. So that's what we did. We took all rheumatology letters from the outpatient department at Salford Royal over a 10-year period, text mined it, put that data into a secure data environment, and then linked it to all the primary care diagnoses over the last 10 years. And just before I hand over to Belay for the most exciting part, just tell you how we go about prevalence of disease. This is just sort of a kind of graphical figure representation of what I was saying before. So what we want to know is the number of people who are disease positive, so that's cell G, out of the total population, which is cell N. But you don't actually know who's got the disease, all you know is who's got the code. And so what we often measure in the prevalence of disease is cell E out of cell N. Often we will do validation of that. So we'll say, well, we know it's not perfect, so we'll go back in the people that we found and we'll see how many of them actually have the disease when we validate them. So you then get to A over N, but what we often don't know is what's happening in cells C and D. So with that suspense, I'll hand over to Blaise. We found what we did try and do that. Just noting that these are very preliminary results. We've got to do a bit more manual annotation about the level of certainty, but Blaise will tell you what we found with this linkage in psoriatic arthritis.
Thank you, Will. All right, so as Will mentioned, now we have access to both the primary care data and secondary care data from hospital. Access to this linked data source gives us an opportunity to quantify two important validation metrics in electronic health records. First thing is it will give us, of those individuals who have case or a code list that requires a positive result, how many of them are real cases and how many of them are false cases. And this is widely reported in validation studies. But it also gives us how many cases we are missing. And this is rarely reported in validation studies of electronic health records because it's almost impossible to do this because of time or cost constraint. And as you see here, it's almost a 50-50%. We can appreciate the importance of having these two metrics by looking at this visual relationship between the true prevalence and the prevalence that we may calculate from the primary care record if we use a code list that have a property of let's say sensitivity of 50% and specificity of 90%. For example, if we use this code list to estimate prevalence of a condition that have 40% true prevalence in the population, we almost underestimate this condition by half. So having access to linked data and having access to the sensitivity and specificity of our code list not only allow us to understand the bias that we are making, but it will tell us how we can also correct for that bias. Can do that by recognizing when a code list from a primary care returns positive, it will do in two ways. First, by correctly identifying the patient that has the condition, and second, by incorrectly identifying patients who don't have the condition as positive. Once we know how this process works, then we can do some mathematical trick and put things in the right place. And then rather than reporting what you see here in the red, probability of code list positive, that's the number usually reported in electronic health record, we will report the estimated prevalence that is adjusted for the sensitivity and specificity of the test. Once we have this relationship, then we can build many interesting things around this, including whether the sensitivity and specificity varies by other factors and so on. Thank you very much. I'll give it back to you.
Thanks, Blaise. So it's really nice to see some of the shock and horror of those figures. And the reason that it's surprising is because doing this stuff is really hard to do. So, you identify a prevalence of 0.2%. If you want to say how many of the remaining people actually had psoriatic arthritis, you have to hunt through thousands and thousands of notes to try and find some signal that somebody had a disease, but the code wasn't there. It's almost impossible. So you have to do the linkage. But the reason that we don't see this very often is because it's punishingly hard actually to pre-process the data, to get access to it, to do the linkage. So I wouldn't recommend going through the pain that we've gone through, but hopefully we found something quite useful. So to summarize what that linkage does tell us, in the discrete location of Salford, where we have managed to do this, it's given us this opportunity to understand the accuracy of primary care data that can then inform national estimates. But it also tells us the value of making use of all of this data that we've got in our hospitals but haven't been able to analyse. So once you pre-process it with text mining, you can learn an awful lot. But I would argue that despite it being useful for historical data, we shouldn't be relying on that in the future. Why are we not coding outpatient diagnoses? We should be improving the structured data in the collection of rheumatology and of all other outpatient-based specialties, so we know the case mix, so we know the medications, so we know treatment response of patients that we look after. And just to finish, just tell you very briefly about the public trust work. We know that when we analyse data that is sensitive and private of people's electronic health record, it's important that they understand what it is that we're doing. There have been suggestions that you should notify the public that you're doing this sort of work. I don't think it's done that often, but in Jigsaw we were keen to make that work. So we did do a public notification campaign. We worked with a comms company called True North. We ended up putting up posters all around Salford, on bus stops, on a big wall here. But we were trying to tell them not just the benefits of doing that, but also the managed risks. And the way in which we look after the data has changed over years. And now there's a sort of move towards what are called trustworthy research environments or secure data environments, where you don't send data out to researchers, you bring the data, so the researchers into the data. But the concepts around that are slightly difficult to communicate. And again, with the communications company, we were able to produce an animated video that I think they did a really great job of conveying these 5 safe principles in a way that was understandable. So that work was specifically for Jigsaw, but it has then further wider implementation in that there's a national programme called the Subnational Secure Data Environments. Greater Manchester is one of those 4 lead regions. It's being rolled out more widely through the coming years. And they need to have public communication campaigns. We'll be feeding what we've learned through Jigsaw for that. And then get a wider uptake for other things that are using secure data environments like our future health cohort of 5 million people. That's 1 million in now, so we're doing all right. So thanks very much. Hopefully we gave you a taster of what we get doing in Jigsaw. Be happy to take questions in the panel. Thank you.
Thank you very much, Will. So we've had 5 speakers actually, not 4, and I'm going to open up for questions. So we did have one question for Celia already in the room. So would you
Yes.
go ahead?
Yes, in the reducing variation in hip fractures, I was just wondering, with the variation in length of stay, how much was possibly due to delayed discharge from factors external to the hospital?
Yeah, so I can't quantify that with the data set that we have, but I suspect a large part of that will be due to inefficiencies in linkage to intermediate care services in communities. One of the reasons I can't articulate that very well is because we don't have a data set that really characterizes provision of intermediate care services that we can link to HES data. What I can say is that those in the analysis of readmissions within 30 days of discharge, one of the strongest associations was seen for those hospitals that had data and knew that the delays, understood the delays between discharge and the initiation of intermediate care. So those hospitals that knew that there would be a delay of, say, more than 2 weeks, which is kind of quite common before intermediate care picks up people, they actually had a lower readmission rate. But those hospitals that didn't have an understanding of how long those delays would be until community care services picked up patient for ongoing rehab, they had a much higher proportion of patients who were readmitted. And I think what that means is that, you know, some hospitals have a dialogue with community services and have an understanding of how long it's going to be before community services pick up that patient once discharged. But if you don't have that dialogue, you can't risk mitigate in your discharge planning, and hence the recurrence of readmission that occurs as a consequence of that.
Thank you. Are there any questions in the chat, Michael?
There's another question for Celia. Find it. She asked about whether the cost reductions were whether the cost reductions were net cost of provisions. Would that make sense to you, Celia?
Net cost of provisions? No, I don't know what that means.
For example, the cost of providing weekend physiotherapy.
So it wasn't the cost of providing the weekend physiotherapy, it was the cost saving on average for a patient caseload in a given hospital. So if you use the cost calculator in the toolkit, it'll say, for example, you know, you have a hospital, your hospital admits 500 people per year. You don't currently have weekend physiotherapy, let's say. So you can select that, and then it'll tell you, based on your caseload, how much money this hospital might save over the course of 1 year if you put in place weekend physiotherapy. Then on a next tab, you can go in there and say, I would like to employ a physiotherapist band X for an FTE of 80% or whatever it is you choose, and it will cost that for you. And then you can export those two elements, the how much you're going to save and how much you need to invest in order to save. And then that can get put into the template business case, which is also another tool on the toolkit, so that you can then obviously expand that with your trust business case logo and template or whatever it is that you need to do in your trust. But the idea is that the tool generates those two figures for you, how much you stand to save and how much you might need to invest in order to save. But often, I mean, for a lot of those things, you would see the saving within a year of that investment because the savings are quite large.
Thanks, Celia. A bit of an echo. I do have a question from Alan.
Yeah, Will, fascinating. One of the things, maybe it's just the hospital I worked in, outpatient diagnoses often changed in the outpatient letter, and often one didn't really know why. I mean, presumably this is a longitudinal record, you'd be able to have a look at how often that was, and particularly something like psoriatic arthritis, where people's view about what the cause is does vary.
Yeah, so we have plans to do that. And in addition to that, we're interested in looking at the level of certainty of a diagnosis and how that changes through time. So in that semi-structured data at the top, you know, I'm somebody who creates those letters, so I know that I write probable psoriatic arthritis. But you don't get, as an epidemiologist, when you receive data sets, you don't get it's probable psoriatic arthritis. You just get that there's a code for a disease. Yeah. But given that we have got the source data and we've got the power in the text mining tools to pull that information, we're going to be teaching the computer how to categorize people into 4 categories of negated. So it says definitely not psoriatic arthritis, or probable, or possible, or definite, or sort of not stated. And of course, there's lots of different ways in which you can express that, but we have to train it to do that. And then we will indeed be looking at longitudinal progression of disease, not just through, was it inflammatory arthritis, then psoriatic arthritis, but was it possible inflammatory arthritis to probable inflammatory arthritis to probable psoriatic arthritis, and then, oh, I actually got it wrong, it was inflammatory osteoarthritis.
Yes, we've got a question. I keep forgetting I'm the only one with a microphone.
Hi, Rosemary Hollick from Aberdeen. I was just wondering if I could ask you about your correction factor when you're trying to capture people who may have a disease but don't have a code. So, and how would that work with, because there is significant regional variation in coding, and there'll be differences in coding, for example, in Scotland or Wales. So, you know, I've done work with routinely collected data sets in Scotland looking at rare rheumatic diseases, vasculitis of the exemplar, and Grampian appeared to have very high rates of serious infection. And that's because we were better at coding them than of course. So I just wondered how you were going to sort of account for that.
Thanks for the question. Yeah. So the correction factor shouldn't be like everywhere. We have to investigate if the sensitivity and specificity of the code lists that we are using are affected by factors, for example, as you mentioned, the geographic factor, other factors. In our case, since we are working in the Southwark area, we may not have the ability to directly investigate geographical factors, but we can have access to factors that vary over a geographical region, and that will help us in understanding if the way people are coding or diagnosed in the primary care change either by demographics or by socioeconomic factors and so on. Once we have that, we can modify the correction factor according to that parameter. Yes. Yeah. And the other thing is, if possible, if we look at this study across the nation in representative areas, then that may give us multiple correction factors in the different geographical areas, and we can synthesize those information and use those information.
Any other questions? Yes.
Yeah, but so firstly, for Lucy, that's a fantastic presentation. Quite concerning to see the variation in the quality of care that people with hip fractures are getting. One question I had was there any association between volume of hip fractures in centres and the time to surgery? Because in my experience, you know, there can be quite a large variation day to day in how many neck femur fractures turn up on the operating list, and you know, with the best will in the world, if you have 8 people turn up over 24 hours and you've only got one operating list, you can't do that. So, you know, could there potentially be a sort of business case of centralisation of services, and if that was sort of taken into account? Sorry, apologies, Celia. Yeah, I'm looking at the wrong bit on the programme.
I'm sorry, can you repeat the question? I'm sorry, I missed that.
Yeah, no, that's absolutely my fault. So I was just asking if there was a relationship between the volume of surgery and the delay to timely surgery, because being a random independent process, the fewer cases you have, the more variation relative to the number of cases, and so if you've got a sort of fixed number of, you know, slots on an operating list per day, then is there potentially an argument for sort of centralisation of process to smooth that out in order to reduce that variation?
Actually, that didn't come out of the models for any of the patient outcomes. I mean, I think most trusts have got a number of slots on their theatre lists appropriate to the volume of, you know, how big that hospital is and the potential volume coming through. I mean, some of the volume indicators that did come through were like busy emergency departments. So, you know, we looked at patient throughput within a, you know, per day type thing and per month. So, so volume and activity of A&E departments does seem to influence different patient outcomes. But actually the number of hip fractures managed by a given hospital per year didn't. But I mean, it's all about whether you have enough slots for your caseload rather than the caseload per se, I think. If you
Okay. Oh, that's interesting. And another question was for Will. So just, I'm really interested in the idea of using natural language processing to read clinic letters and to sort of, and to augment that outpatient data set, which is obviously, very important for rheumatological disease. I was just wondering, did you pre-train the sort of the phenotyping algorithms that you were using, or is there sort of a publicly available suite of algorithms that are already pre-trained that your researchers can apply in these sorts of projects?
Yeah, so there are existing tools, but you need to fine tune them according to the locating, like the source data that you're using.
Yeah.
We've used two different things. So we've used a company called Intelligent Medical Objects, where we did our first round of work of kind of evaluating how well it performed, and then we're repeating that now with more open source data and tools called CogStack or Medcat that comes from King's. Richard Dobson leads the group there. And that is getting traction around the NHS, and people are reusing that, and we'll be looking to pass the models that we got back to them so they can kind of continue to redistribute that.
Fantastic.
Right, we are rapidly approaching a break. Oh, we've got one on the question online.
We can keep going with this questions. There's still lots of
Yes,
questions.
please go.
And there's a couple of questions for Michael. I'll pose both to you. The first is about the waiting times for public transport. So if you consider a patient has a 3 p.m. appointment, they'll arrive by car by 3 p.m. Then if public transport is less flexible, so if the bus arrives at 5 minutes past the hour, they'll have to get the 2:05. And the question is whether you've accounted for the extra waiting times for patients for public transport. The second question is whether you considered using any waiting well strategies such as escape pain groups.
So to answer the first question, it will. I can't speak exactly to this, so maybe Rosemary can inform a little bit better. But actually, we don't know what times exactly people's appointments are, so we can only account for the travel time door to door, including potential changes that might occur. And yeah, naturally, the burden is quite a lot higher, and it's something we have thought about in terms of, for some people who have to travel a considerable distance, it may be a half day task to, including getting ready. So it's not just the objective time measure of travel. It's, if you've got multiple comorbidities, it may take you hours in the morning to get ready to go to an appointment, and then multiple hours to travel, hours to attend to your appointment, and then return. And it might be you lose an entire day to that. So that is something it's not accounted for, but it is on our radar. Sorry, could you want to repeat the second question for me?
Whether you used any waiting well strategies such as escape pain.
I'd have to speak to. I'll pass that to Rosemary eventually.
Yes, so this analysis was, so I did the MAP study, so I should say who I am. So I think what we were just doing was trying to quantify, access to care, but as Michael was saying, there's a much wider qualitative piece of work which is accompanying this, and clearly this is not just about access. This is about perceptions of and expectations of care. As Alan was saying, what has emerged as a really big thing is about caring responsibilities, people as carers themselves or being looked after by others informally, and around access to care. So I think in answer to the question, this is providing local services, hopefully with data on their local population, which they can use to help improve services, and then it's what is the solution, and how is this about signposting, for example, because the qualitative was also, it's not just about the presence or absence of services, it's about whether people know they're there and they can access them in a timely way, and I think that's what the potentially some of the solutions will come in. So I think this is just the quantitative framework. It's a lot more complex than that, and then we can sort of specify the solutions from there.
Certainly, there's a lot of work to do there, isn't there, with local authorities and policy and influencing in terms of provision of service. So it's much wider, isn't it? It's great. Michael, the more on that?
Yeah, we'll finish with a couple of questions to Alan, if that's okay. There's a couple of questions in the chat. One question, Alan, around the use of decision support tools, if you consider using those. And there's another question from Celia as to how many older people consented for TKR and THR and consented for post-op delirium. That's been considered.
The answer is we're collecting that information. That I don't know. It's an important topic about post-operative delivery, but as far as I know, we haven't specifically collected the data, which is a shame. Yes, the aim is to have a decision support tool, but I think the essence is that the current decision tools need to be co-designed with patients in mind, based on the kind of information that they think is important. And I think, as I say, at the moment, a lot of the tools that, as I understand it, are based on particularly methods for assessing operative risk and the level of certain symptoms, and not really considering the impact of the pre-existing health problems on the patient. So that's the ultimate aim, to improve the tools.
Okay, so just one change to the programme for the next session, I'm afraid. Unfortunately, Toby Watt is ill and is unable to be with us, which is a real shame. So I hope we can send him our best wishes and hope he gets better very quickly. So we are starting with our first speaker, Mark Ashworth, who's the Professor of Primary Care at King's College in London. And then we'll be going to our third speaker, John, after Mark. Okay, so Mark, are you okay to come up to the podium? I will introduce you in a second. I'm going to give you the microphone. So Mark has combined an academic primary care research career with a clinical career in inner city, general practice. His research interests include multimorbidity and the pathways to multimorbidity, antibiotic prescribing and reducing the risk of antibiotic resistance, psychosis and psychometrics, and patient-generated mental health outcome measures. That's a real broad range of topics, Mark. So today he's going to be talking about patterns in chronic pain with the chronic in brackets. So that's interesting to find out why it's in brackets. Anyway, I'll hand over to Mark. Thank you very much for being with us, Mark.
Thank you very much, and thank you for the introduction. Apologies for the drama queen bit of the limp as I walked onto the stage. I'm afraid I pulled a tendon, and only now, after 30 years of general practice, am I starting to realise how blooming debilitating something like this is. Thank you for the introduction. I'm going to talk about none of those things that you mentioned in the introduction, but you can ask me about them later. What I am going to talk about is pain and chronic pain and trying to identify it, because GPs are terrible at identifying patients with chronic pain, as we have found in the study I am going to present to you. We are very good at categorising, classifying biomedical model conditions. So ask any GP what their rate of heart disease, hypertension, cancers, diabetes, etc. is. You'll get an instant answer on prevalence, because they're all QOF conditions. They're all incentivised through the GP incentive scheme called QOF. Alas, chronic pain doesn't appear on any of those classifications. So GPs are not incentivised to know about their chronic pain patients or work with their chronic patients, or even who has pain or chronic pain. And it took a very clever algorithm, name check coming later, for OBH, who helped devise the algorithm, outcomes-based healthcare. But it was only thanks to that algorithm we were able to find people with pain and then subdivide them into those with chronic pain, by which we mean pain for 3 months plus. Now, as a primary care perspective, we know that there is primary pain and secondary pain. And secondary pain is pain due to known painful conditions. I'm proud to put down there, as well as the obvious ones, endometriosis. We really need to include that in all our definitions these days. Come on, that needs to be right up there. But a lot of pain doesn't seem to have any biomedical model cause, and it's just primary pain. Fibromyalgia, aches and pains of the muscles, chronic daily headache, which may or may not be, well, it probably is a variant of migraine, complex regional pain syndrome, irritable bowel syndrome, but all very painful, but without a clear biomedical model underlying. Now, the other way of looking at this is the epidemiology of chronic pain, because as well as having secondary pain and primary pain, we need to look at what that distribution is, and it is roughly a third each. A third is no underlying cause, a third is there is an underlying cause, and 15% is a mental health condition. So actually, we all have to be open to the mental health agenda that may be bi-directional. It may be part of the causation, it may be part of the consequences. I certainly, as I was struggling to make my talk on time, realising how slow transport times are when you have to get to Farringdon Tube and go up each step one at a time. I thought, how can I find the phone number of the organisation, of the organisers of today's talk to tell them I'm going to get here, but only just in time. So I felt my own stress over that. So I think whether stress is the cause or the consequence, we have to be open to the fact that there is a mental health dimension to chronic pain. Now, how much chronic pain is there out there? Well, we have to understand the distinction between primary care prevalence and community prevalence. If you do a community survey, obviously rates are going to be higher. I've cited the rates there from the Health Survey of England, probably the best known, most nationally representative of the community surveys. And of course, that's going to be higher than represented in primary care. And the reason for that is that many people with chronic pain, thanks very much, I go to the pharmacist. Thanks very much, I don't think GPs have got much to offer. Or, thanks very much, they saw the GP, but the GP didn't bother to code it or somehow got distracted by another component of the consultation. So it doesn't tend to get very well recorded. So as far as GPs are concerned, prevalence is 10.1%, and that comes from the Cambridge Primary Care Unit. So that's a bit of a drop from 34% to 10.1%, but that's not what we found. So this is where I do need to mention outcome-based healthcare, OBH, because they helped derive an algorithm which changes how we find chronic pain patients. The 10.1% is based on Cambridge's best effort looking at long-term analgesic repeat prescriptions. If you're on analgesic repeat prescriptions, hey, you've got chronic pain, haven't you? Good point. But you miss all those patients who have a painful condition who are not on repeat prescriptions of analgesics, who actually, they and their GPs are probably following the best nice chronic pain guidance, which says, don't just reach for the prescription pad. There are other approaches like exercise, like addressing the mental health side of things, maybe social prescribing. So the 10.1%, by only focusing on prescribing, misses a large chunk of patients with chronic pain. We are the first to publish using a definition which includes painful conditions, even if they're not on long-term analgesics. What are those painful conditions? I showed you them earlier. And yes, it definitely does include endometriosis. It includes fibromyalgia. So this is what we found. And oh my goodness, not quite sure if you can read all the labels on the left-hand side of the graph, but most of those conditions are well recognised and categorised by GPs. We know that 19% of our patients have an anxiety disorder, 13% have depression, 11% have asthma, and 11% have hypertension, and so on. But none of us knew that chronic pain was 17.3%. So we've not quite doubled it, but nearly. It's gone up a lot, and it's right up there, and it's invisible within QOF. It's frankly invisible to most GPs' concerns. Now, if you're looking at Black ethnicity population, and this is where we really drill down to the data. So here we are using OBH algorithms, and using my data set, I'm primary care research lead for Lambeth DataNet. It's 1.6 million patients registered at all GP practices in Lambeth since the year 2005. And we're able to look in great detail. What our GPs are brilliant at is classifying ethnicity. So you don't get much ethnicity breakdown in national GP data sets, but in Lambeth you do. We are attuned to the issues of ethnicity. So we can drill down and find out, this is the big finding, chronic pain, top of the list suddenly in Black ethnicity patients. Have you got the figure? 26.5. So it was 17.3% in all adults. It's 26.5% in Black ethnicity. It's higher in women than men, a bit, 21.9%. But then you drill down, oh, I'm sorry, I've just gone backwards. You then drill down into Black ethnicity females, and it goes up to 34%. Hold on, this is going up a lot, isn't it? I'm not there yet. You wait for it. We do further categorization of our data, and in Black Caribbean women, so not Black ethnicity, it's subdividing ethnicity into Caribbean and African. And if you speak to our community, the Black community says, look, we're very different, Black African and Black Caribbean, very different cultures, very different life experiences. And in our area, Black African tends to mean West African. And Black Caribbean women, 54% have got Caribbean pain. Probably ours is the only data set that could show this, because we've got that granular data. Plus, don't forget, we're using the OBH algorithm. So this is not just those patients on long-term repeat prescriptions of analgesics. And then guess what? As soon as we presented these figures, along came BBC London, Tara Welsh. You may know her as correspondent, social correspondent in BBC London, and she immediately honed in on this. And there was a BBC News item, interviews on BBC London about this. Now, perhaps I could have left it there, because that's the job of a researcher, to shine a spotlight on health inequalities. And this counts big time as a health inequality. But then people say, what are you going to do about it? You know, well, we've done our job, we're researchers, we've looked at the data, I do big data, that was my analysis. Thanks, that's kind of, is it my responsibility? Well, actually, maybe yes. Maybe it's not my strong suit, but maybe I need to collaborate with those people for whom it is their strong suit. So we collaborated with influential GPs in Lambeth. We collaborated with Stockwell, primary care network. You've probably heard of PCNs, don't ever get into primary care politics, but they're the groupings of 3 or 4 or 5 GP practices meant to be working together, and serving a community, and they kind of do, to a greater or lesser extent. In Stockwell, they really do. And when they saw this data, they thought, we've got a problem with our Black ethnicity community. And they added something else to my research, which I hadn't anticipated. What they added was that the chronic pain patients, regardless of ethnicity, but just chronic pain patients identified by the OBH algorithm, they ran that algorithm throughout Stockwell. They were also the highest GP consultation rate attenders of any of the long-term conditions. You saw that list of long-term conditions. You know, people with hypertension do pitch up from time to time. People with diabetes pitch up quite a bit. People with chronic pain pitch up even more. So they really wanted to do something. They had my figure, 54%. They had their data of high consultation rates, and they said, bang, we are going to devise an intervention. They identified every person with the algorithm. They texted them, and however you recall your patients, tested them, I imagine, and got them an appointment with a social prescriber. and the social prescriber employed by the network really worked with each one to look for alternatives to analgesics, following NICE guidelines, and alternatives to GP consultations. And it's really transformed care in Stockwell. It's going to be rolled out throughout Lambeth. Here's an evaluation from King's Health Partners, the PEACS project, they call it, PEACS project, and it's reporting to NHS England too. So let me end on that optimistic note. Thank you.
Thank you, Mark. We are taking questions on all the speakers at the end of the session, so you don't need to stay standing and rest your leg. Thank you very much indeed. It's really interesting. Next up, we have John Beth, who is a professor of chronic disease epidemiology at the University of Manchester. John is leading the development and use of digital methods in epidemiology to integrate and interrogate electronic health records and person-generated data to track the occurrence and progression of disease and to identify causal mechanisms, remotely monitor and assess patients and deliver digitised interventions. Again, a lot. Over to you, John.
So, thanks for the introduction and thanks for the invitation to come and present some of the work that we've been doing around the estimation of disease in the UK. And this was funded through Versus Arthritis, through a project called the Health Intelligence Analysis. And what I'm going to do is I'm going to show you some data from the prevalence and incidence of psoriatic arthritis and fibromyalgia. And as we go through this, I think it's really interesting some of the discussions that we've been having around primary care data and the nuances within primary care data. I want you to remember the data that Will just presented around missingness in primary care data when we compare that to secondary care data. But also as we go through this, I think we need to try and find a middle ground because as Will quite rightly said, doing that linkage is incredibly hard. And one of the ways to resolve that is, as we go forward, is to improve coding in secondary care. And so until we wait for that to happen, using primary care data to estimate prevalence and incidence is going to continue. So what we've got here is a solution, one solution, for improving the accuracy of those estimates. So just to remind us why we're doing this in the first place, we know that contemporary estimates of disease inform healthcare research, service delivery, resource allocation, and that's nationally and locally. And those estimates are also of interest to charities, Versus Arthritis and others, and patient organisations. And these are frequently estimated using routinely collected primary care data, including the clinical practice research data link. And that's the data set that I'm going to focus on today. So we know there's a number of problems. There's a number of problems within those data sets. So if we first focus on data problems, we've heard about the representativeness of the source data. So CPRD often, highlighted its representatives in terms of age and sex, socioeconomic status. There is historically missingness in that data set around ethnicity, and we've just heard from Mark how important that would be. There's also the problems of incomplete case ascertainment. So how do we know that the number of cases that we're identifying within those data sets is an accurate representation? And that's related to misclassification as well. There's also a number of estimation problems. So if we try and estimate, particularly at lower geographies, it's challenging. It's challenging because when we look at relatively rare diseases like psoriatic arthritis and fibromyalgia, when we go to lower level geographies, we tend to end up with very small numbers and often with zero cells in our analysis. But there's also the sort of related problem of changes in health geography areas. So in England, in 2012, we had 200 CCGs. Those morphed into 106 CCGs in 2021, and more recently into 42 ICSs. Now, the problem with that is that as we move through those transitions in geography, there's often a delay in the health data catching up with that.
So in Scotland and Wales, we have 14 and 7 health boards respectively, and in Northern Ireland currently has 5 health and social care trusts, and they're planning to move to ICSs, and that was planned pre-pandemic. It paused, and now they're picking that back up again. So we just need to be mindful that these geographies are changing over time. And one of the issues with that is that there's incomplete mapping between those. So as I said, the majority of health data before 2022 still in CCG format, but there's also limited availability of health geography structure. So when we were doing this work, we were struggling to find the sort of distribution of important factors within ICS data, but over time that becomes more apparent. So here's our solution. We've developed a flexible data preparation and statistical modeling strategy. So this identifies potentially missing cases in data sets. So we're interested in looking at definite cases plus probable cases. We calculate annual rates, so incidence and prevalence, using a Bayesian multi-level regression with post-stratification. Belay's in the room. If we have any technical questions around that, we can go to Belay. We then standardize that to the UK population. So we use ONS data, which is good for England, move outside of England, and then it becomes really complex to try and get that data, that population data. But we did achieve it. And then finally, we use all of that information to predict at lower level geographies. So where that information may not be readily available, we can use our modeling strategy to predict an estimate at lower level geographies. So this accounts for systematic differences between source data, UK population data based on these factors you see here: age, sex, socioeconomic status, and region of residence. And then we provided estimates stratified by age, sex, UK region, and index of multiple deprivation. So just in the interest of time, I'm going to show you the rates overall at a national level, so for the UK. But if you're interested in rates at these lower level geographies, you can go online. There's a publication, which I'll show you at the end. And in the supplementary material, all that information is there. So what did we find? So firstly, psoriatic arthritis. So between 1991 to 2020, we identified just over 26,000 eligible cases. And the breakdown is 78% of those were what we call definite cases. So they had a PSA read code in the primary care record. We then identified 2 probable definitions of PSA. The first being a read code for psoriasis, plus a code for arthritis, plus a code for treatment related to arthritis. And then the second, which was 4% of all eligible cases, were read codes for psoriatic arthritis plus seronegative RA, or axial spondyloarthritis, and or spinal disease. So out of those 26,000 cases, 52% were female, and the mean age at diagnosis, so first recorded read code for PSA, or the first date at which they satisfied the probable cases 1 and 2, was 50. This is the data showing the observed and standardized prevalence of PSA between 1991 to 2020. So if you just focus on A on the left-hand side, the black line shows the observed prevalence overall, and then red is definite cases, green is probable case 1, and blue is probable case 2. So overall, in 1991, to the left-hand side of the graph, we had 195 prevalent cases observed among 757,000 individuals, and that was an observed prevalence of 0.03%. When we moved to 2020, we had 10,287 cases in 2.8 million participants, and that was an observed prevalence of 0.36. So you can see that over time, that equates to a 12-fold increase in the prevalence when we look at recorded prevalence within primary care. Now, of course, there will be a whole range of reasons why that's the case. There will be differences in coding, differences in referral, differences in awareness. But overall, in CPRD, that's the rate of increase that we found. This is similar data for the observed and standardized incidence of PSA. Again, on the left, broken down by case definition, and on the right, you can see the standardized data. So in 1991, the incidence of observed incidence of PSA was 8.9 per 100,000 person years, and that had increased to 16.9 by 2020. So about a twofold increase. In terms of the standardized data for both prevalence and incidence, the rates didn't vary much when we standardized using our modeling strategy. So a very similar rate of increase was observed between 91 and 2020. Now fibromyalgia. So in CPRD, we identified 628,851 cases of fibromyalgia between 1991 and 2019. And I'll explain why we all went to 2019 in a minute. So definite cases, so had a fibromyalgia read code for 451,000, and then suspected cases or probable cases, which satisfied the criteria of muscular rheumatism or fibrositis unspecified, were 177,000. So 72% definite, 28% suspected. 81% of all those cases were female, and the mean age of diagnosis or satisfying the suspected probable definition was 45. So this is the observed and standardized prevalence, so very similar to the PSA data that I showed you previously. On the left hand is observed fibromyalgia cases. In red is the definite cases, in blue is the probable cases. And what that shows over time is that the number of cases is increasing substantially for definite cases, and for blue is decreasing over time. And again, this will be related to changes in practice, changes in coding, changes in published criteria for fibromyalgia. But what we found was that when we looked at the observed data, the prevalence in 91 was 0.33, had increased to 1.12 in 2020. But if we look simply at the definite cases, the prevalence increases from 0.01 in 1991 to 1.04 in 2019. And that equates to a 104-fold increase. But again, that's caveated with all of those issues around coding, diagnosis, and awareness. This is data on the incidence of fibromyalgia, so a very similar pattern. As you can see on the left-hand side, incidence for definite cases in red increases over time, and incidence for probable cases in blue decreasing over time. So in 91, the incidence was 132 per 100,000 person years, and that actually slightly decreased. This is for overall rates to 97 per 100,000 person years. And that makes sense because if you sort of plotted a line through that definite and probable case mix, then you would see that it slightly decreases over time. But if we look at definite cases, the incidence is 3.5 in 1991 and 96.2 in 2019 per 100,000 person years. And again, that equates to an increase 27-fold over that duration. So what are the limitations? We know the strengths of this: big data, large numbers, and a very, very robust statistical modeling procedure that's flexible. Limitations are that the observed changes are driven by a number of factors: data quality, awareness, coding, diagnosis, recording, in addition to real changes in prevalence, underlying prevalence and incidence. What about missing cases? Well, I mentioned Will and Belay's presentation earlier on. That's an issue that we need to be thinking about, but that perhaps is less relevant for conditions that are mainly diagnosed in primary care, such as fibromyalgia. But for the PSA data, could be something that we really need to consider. And there's also the issue of missing covariates. So while over time in CPRD these have improved, there are issues around the availability of ethnicity and other important covariates, such as BMI, that we know are strongly related to musculoskeletal pain conditions, such as fibromyalgia, and may be related to PSA. So if you're interested, this was published a couple of weeks ago. This is the publication for PSA. It presents the overall data for nations across the UK, and in supplementary materials present all of the stratifications at a national level and at a regional level. We've also made the modelling strategy freely available, so you can go here and go through to the supplementary link and find the modelling strategy, and you can use that to provide contemporary prevalence estimates for diseases, including rare diseases, using routinely collected primary care data. Thank you.
And last but certainly not least, we have George Peet, who's going to be talking to us about the MIDAS programme. So George is the Director of the Centre for Applied Health and Social Care Research and Professor of Clinical Epidemiology at Sheffield Hallam University, and he's joined by Jonathan. Is Jonathan here as well? Online. Welcome, Jonathan, online. So Jonathan Hill, who's the Professor of Physiotherapy at Keele University. So George is a chartered physiotherapist, trained in public health and epidemiology, and director of the Interdisciplinary Centre for Applied Health and Social Care Research, and Professor of Clinical Epidemiology at Sheffield Hallam. Before joining Sheffield Hallam, George worked in the Versus Arthritis National Primary Care Centre of Excellence at Keele University, designing and undertaking clinical epidemiological and data intensive research to understand and improve musculoskeletal health and care. Got to write bios in shorter sentences. So, with Jonathan, welcome, Jonathan. Jonathan Hill is the Director of Research for the School of Allied Health Professionals and Professor of Physiotherapy at Keele University. He's been involved in the development of important MSK interventions in the last 10 years, including Start Back and the MSK HQ. Jonathan is also supporting the development of the National MSK audit, looking at data in a community setting. So I'll just hand over straight to you, George.
Lovely, thank you very much, and thank you for the invitation to speak to this project, which is funded by the Oliver Bird Fund from Nuffield Foundation and co-funded by Versus Arthritis. So we're 3 years into this programme of research. We finish in March 2025. I'm going to give a bit of an outline of some of the overview of the programme of research that we've been doing, some of the emerging findings, and an important concern really with all of these local data integration pilots has been the search for generalisable, scalable insights. And so I'm going to hand across to Jonathan Parker here, who's going to make the link between the MIDAS programme and plans for a national MSK audit. So just a quick recap of the rationale for our particular programme. So our focus is on those musculoskeletal pain conditions that cause greatest impact, so low back pain, osteoarthritis, ones that you've heard from Mark already this morning, and for which we struggle with quality, consistency of coding, a lack of reference or gold standards for these diagnoses, and typically management will actually occur mostly within primary care, general population, and community settings. Actually, there's an absence largely of hospital-linked data for many of these conditions. So our focus was on how to better integrate data upstream. We know there are some important gaps in routinely available data, and our intention was not just to analyse existing data, but try and create and link new data from patient self-report into this. And of course, we've heard from speakers before here, you've got plenty of ammunition to criticise the presentation around the challenges in trying to link, analyse and report these data. So a little bit just about the sort of concept that informed the design. So this is lifted from King's Fund, but I guess we're conceiving of musculoskeletal health being determined not just by what's going on in the healthcare system, but behaviours, lifestyles, the places and communities where people are living and working in these wider determinants of health. So any opportunity to make sense of this has to try and link data that speak to those factors. And our particular programme has looked specifically at this cross-classified structure where individuals are belong at the same time to general practices, and that's the sort of nested within then primary care networks, etc. I won't bore you with the stuff that Mark didn't want to bore you with as well. And simultaneously part of neighbourhoods, wider areas and local authorities.
So the setting is North South and Stoke-on-Trent, and there's just a bit of a description about the population there. Our sample frame for this study were 30 general practices, and we worked really hard, I have to say, and as COVID was being released, if you like, from practices were being released from COVID, to try and involve practices that covered across all of those PCMs, including practices that were serving some of the more deprived and ethnically diverse populations or communities within our patch. And that included practices that had literally no previous experience of research involvement. And the data collection linkage piece was really looking at these sort of 3 levels within that sample frame. So the general population, so undertaking a cross-sectional survey, a random sample of adults, registered with those practices, looking at consecutive consultants presenting musculoskeletal pain conditions for those practices, and then also looking at the local community MSK service consultants. Data collection for those first 2 is complete. Linkage is now well underway, and for the third, this links to the national MSK audit ideas. This is the first of many busy slides. I don't expect people to sort of look in detail at all of this, except to emphasise really the sort of data sources that we're attempting to link here at each level. So, including patient-reported surveys linked to the primary care electronic health record data, linking through for consenting participants to hospital data and community data sets. At the level above, at practice level, clearly there's a wealth of data already available, whether it be prescribing, patient experience, workforce data, but we supplemented that with practice-specific survey to understand some of the most specific aspects of provision of MSK services and pathways. And at the neighbourhood level, clear emphasis on deprivation, but we also use some data on model estimates of ethnicity within those neighbourhoods. Drilling down even further, and again, these slides will sort of post up afterwards. In terms of the content of patient-reported surveys, so we went through a fairly exhaustive process mapping to existing recommended core sets, as well as consulting our community of practice, and also our patient advisory group for those. So you get a flavour of the sort of information that was collected. For this point of care study in general practice, and this was an online data completion. Patients were invited by an SMS that was automatically sent from practices, triggered by an MSK relevant code that was entered. We also did, and particularly under the advice of our advisory group and patient advisory group, was to offer an offline route for completion of that. I have to say, in the event, it wasn't used. So actually, it was predominantly online responses that we received for this. The electronic patient record included a lot of work into trying to understand the codes that might be relevant to MSK conditions. So about 500 actually that were narrowed down on the basis of patterns of usage as well as relevance through a consensus process involving both GPs and clinicians. And looking at also at things like fit notes, prescription data, extracting information on referrals and comorbidities, but only the structured element of that primary electronic health record. The result of that, I guess, is a series of, what we're terming tools here, effectively methods that we've used to try and derive different measures, indicators, etc. from this. So, a code list for around MSK pain injury, a code list around multiple comorbidities, or relevant MSK referrals and process of care, which we're posting up on the itself. It's a precise framework and GitHub wants to be accessible. But also from the data collection instruments, where that be a first contact practitioner template for entering data, as well as those questionnaire items. Some of the models that we've used, some of the maps, and I'm sure you want in a minute, have been published in this article in the European Journal of Pain, and our hope really is to try and do a lot of the learning so it's freely accessible, so it can be scrutinised and very useful used. So a quick sense of what we're sort of doing with linked data and some of the applications of those data. And again, it's, I think, sort of emerging findings here. This has been presented before, so I don't want to dwell on it too much. But this is effectively a neighbourhood-specific map of the prevalence of chronic pain. We've got a similar one for the prevalence of high impact chronic pain derived from those local survey data. Confirming what I suspect a lot of people would know, which is that there is huge variation between neighbourhoods within the same integrated care system. So it's not just inequalities sort of north-south, but actually within any one parish in these integrated care systems, big inequalities. This is by primary deprivation. And we can see, though, that one of the other caveats on this with the plot at the bottom, those estimates, despite the fact that they were derived from over 4,000 respondents within just that local area, still have quite wide confidence limits around them. So despite the fact that we can do fairly intensive data collection, there is still quite a lot of uncertainty about these things. When we're presenting and working with commissioners or other managers, we have to find ways of trying to express some of the uncertainty around these estimates. One of the questions that we've been pressed on multiple times is, yeah, but can you say anything about, beyond North Staffordshire and Scotland-on-Trent? A lot of your estimates is always very specific to that population. And the honest answer is we don't really know. I think we've tried sort of principled approaches here to try and work out, well, how might you at least identify some of the limits beyond which you really shouldn't try and generalise. So here's an approach using matching. So propensity score matching based on age, sex, rurality, deprivation and ethnicity for each of the LSOAs in England, and trying to look at the extent to which they are radically different from the ones that we've been doing our study in. And there are at least a fifth of neighbourhoods across England that are very different and predominantly on ethnicity. So with the North South and Stoke, not such an ethnically diverse population. And one of the limits that we might impose upon any sort of generalisation is say, well, actually, we ought to be very careful about trying to generalise the populations that looked at very different sort of composition to them. That said, there's still a lot of assumptions in transporting estimates from one local area to another, even if that population structure looks similar. One of the things that we did do with that information, though, was to then intentionally oversample from areas within North Staffs and Stoke that do serve more diverse and deprived communities. So that was part of our process of recruiting practices into Linus. But we also undertook an additional booster door-to-door survey to complement our conventional mail survey, knowing that we were having and were likely to have relatively low response rates from those communities. I gave you the description about the variation in the underlying prevalence of chronic pain. What if we sort of superimpose on top of that primary care consultation rates for MSK? So again, this is a bit of a snapshot here from recruitment into that live STP study. There was over 18,000 adults consulted during the period that we were recruiting for, and that was about 9% of the adult population aged 18 years and over, and that was over an average of about 4 months recruiting per practice. There's very little relationship that we can see between the consultation rates, which vary from one practice to another by about twofold, and the underlying estimates of the prevalence of chronic pain. Now, there's lots of criticisms here that I think can be levelled at that. Are we comparing like with like? We've got estimates of chronic pain, which you've just heard will encompass lots of non-musculoskeletal causes. And of course, we've heard of all the caveats and limitations around counting cases from the primary care record. One of the things that we intend to do is, one, apply this more specifically into our definition of low back pain, which we have into estimates, but also include longitudinally over time to see whether or not we're seeing this as a very consistent pattern, or whether or not we're just dropping in a particular snapshot. Oops. If we take a step on from the community level patterns into what's happening with that inequality gap once we're into people presenting to general practice. So here are some initial findings. On the right-hand side, just a crude estimate of the mean MSK scores, comparing those people living in the most deprived quintile of neighbourhoods in our sample versus those in the least deprived, showing that very clear gap. So lower scores indicating worse musculoskeletal health, a fairly sizable gap at just initial entry into the consultation. And if anything, and I think I have to be careful not to overinterpret this before we do the full modelling of these data, that gap may be slightly increasing. So our most deprived patients are actually emerging at follow-up, having experienced some improvement in MSK health, but actually at a level that's still below the rate that's actually presenting in the least deprived patients. I'm going to skip the learning to the end, and I'm going to hand over to Jonathan now. So hopefully you're on the line there, Jonathan, ready to pick up the baton.
I am. Can you hear me all right?
Yeah.
Great. So if you can go forward, George, thanks. I'll just keep shouting next slide if that's all right. So one of the exciting things about being involved in MIDAS has been the spin-off projects, and I've personally not been involved in a project that's had so many exciting further ramifications and other projects. So it's a privilege to be part of this. And I thought I'd talk about 3 specific projects. There were a number I could choose from. Just about how we move from this kind of local health intelligence that we're getting from MIDAS. How do we take the toolkit and the learning that we're getting to elsewhere, to other ICSs and take that nationally? So I'm going to start by talking about the National MSK Audit and Research Database. This is I'm leading this in alongside Roanna Burgess, who's a consultant physiotherapist and senior clinical academic at Keele, and Professor Kelvin Jordan, who's Professor of Biostatistics. So next slide, thanks, George. So really what we've heard already is about the data invisibility in the community care setting, and there's a real need for us to start to plug that gap. So the National MSK Audit is a pilot that's seeking to try and address that. Our ambition is to get national data collection from around 40 services. Remember that a lot of community services have first contact practitioners, physiotherapists, who are often working in general practice. So we need to get data from both of those sort of settings, and that's our ambition. We are wanting to collect that community data and integrate it then with patients' primary care record and secondary care data. We're doing that through a model of consent. So patients who are collecting and inputting data, routine data into these community services, are consenting to having that data linkage piece. And the data is going to sit within one of these secure data environments. We've heard about the different ones that have been set up, and it's the West Midlands SDE that we're going to use, and we're collaborating with them to be the place where we hold the data and analyze the data. And our job will be to benchmark and do the provider level reports, as well as the national reports. We're also wanting to have interactive dashboards using Power BI, and clearly we're starting to have some data sets through MIDAS, which is helping us to think about what those are going to look like and start to plan those now. We've also got a big community practice meeting regularly, and I have to say it's great to see the level of engagement and enthusiasm across the country to be part of this pilot. And our big aim here is to try and get this HQIP commissioned so that we could have a sustained national audit. And it's looking like we're on an 18-month journey to try and get that. But before we do, we clearly need to prove ourselves through this pilot. So George, if we could have the next slide. To get a HQIP commissioned national MSK audit, there are a number of things that we have to do, and they ask for evidence for. These include showing that you've got improvement-driven quality indicators, that you've thought about your scope and audit design, and you've sort of demonstrated that you can do that. Clearly, we've started to do that with MIDAS, and we will hope that the pilot will be able to demonstrate that wider and elsewhere. It's got to have alignment with the government priorities, show impact and value for money. And, I think we already know about the need for that particular national audit, but we also need to evidence the professional and patient support. So that's the challenge ahead of us. And I would encourage you, if you're not already part of it and you work in an MSK community service, do consider taking part. Next slide. Thanks, George. The current situation is that we're in an onboarding process. You can see there's 5 stages to onboarding services to be part of this. We've currently got 46 who have expressed an interest in taking part from around the country, which we're delighted with. 9 of those 46 have already got their governance sign-off in place, so data sharing agreements in place, and that means that they need to embed our consent form, data privacy statements and things within their routine data collection. And we have 3 who are currently in that data alignment process of just working out what does the Keele data dictionary look like, and just making sure that they have got their routine data collection aligned. The next step will be validating those over the next few weeks, and then they will go into live status. And we're hoping in the new year we will start having services take part. And there's a link there you can see. If you just Google Keele and the National MSK audit, you'll find us, and all the information you need is there. Next slide. Thanks, George. The second project I just want to talk to you quickly about is about how do we develop the improvement-driven quality indicators within this space. We've heard from GERFT, we've heard about the secondary care indicators from things like the National Hip Fracture Audit, and Cecilia was presenting earlier. We really need to develop some clear quality indicators for this community and setting. And one of my PhD students, Alex Braybrook, is leading some work around that over the next few years. Next slide. Thanks, George. We've already heard, if you look at the other audits, clearly, this is, I think the previous presentations have already explained this slide about the importance of knowing what those quality indicators are, having those agreed, and then having dashboards that help services interrogate their own performance and look at how well they're doing, and slice that in lots of many ways. So key to part of this is getting the dashboards, and for us understanding, well, where's the variation, which indicators really show what good looks like and helps us identify the outliers the best in a way that really informs quality improvement. And that's the journey that I feel that we're on just at the moment. Next slide. Thanks, George. Clearly, we need to be aligned to the national strategy. There's no shortage of existing MSK indicators from a range of different documents. Here are some examples, and we've kind of thought of this as some of these are themes, such as personalised care, and then we've got the example indicators that might come under that, like percentage of patients with a discharge plan, or percentage of clinicians who are using shared decision-making tools. And actually, we find that there's no shortage of indicators or themes, but we're in a process of trying to map those and really get clarity and national consensus around what we might be using. Next slide. Thanks, George. So the journey that we're going on, just to mention here as well as some of the key MSK strategy documents that are important for us in this particular space. And the sort of themes that you can imagine are varied, but you can identify often not the quality indicators, but the themes from these kinds of documents, whether that be around reducing waiting lists, whether that be about patient-initiated follow-up, shared decision-making, personalised care, community-based MSK hubs, employment advisors. It's all in there, and that's a key thing we're needing to look at and identify. Next slide. Thanks, George. So poor Alex is on quite a journey. He's right at the very beginning with his systematic review at the start of the PhD, where he's been tasked with identifying the themes and also mapping the quality indicators that we see in the literature. And then we're going to go through a process of getting the expert input and wider Delphi study to really engage the clinical community, and then go through with our data sets, what does it look like, how well are these indicators working, and end up with a feasible list that we can collect in routine data sets. Next slide. Thanks, George. And this is early findings. Please don't sort of tweet this. We're still in work in progress, but I did persuade Alex to send me the list of current themes that are emerging from his systematic review. And you can see he's put here, there's 278 different quality indicators across all of the literature, and they fall into these kinds of themes. And clearly that's 12 here I think we've got is more than we would be able to have. And most of the national audits try to limit themselves between about 5 and 8. But we need to go through that process now of deciding exactly which indicators sit under which themes and that's the journey I think we need to get to in the next 6 months as part of what we need to do to demonstrate our readiness to head towards a HQIP national audit. Thanks, George. Next slide. So that's just a reminder of the journey we need to go through. I think I've talked that through. Next slide. Thanks, George. And the last project I just wanted to mention was just how important it is when you are collecting data routinely and systematically of being able to then inform wider discussions within an ICS about changes in terms of organisation and the direction of treating musculoskeletal problems in community and primary care. And the big question we've sought to help with locally at Keele is a question around what happens when we use digital solutions, in this case an app called SelfBack being combined with risk stratification using the StartBack tool. What happens when you get clinicians to use risk stratification and then provide SelfBack as a self-management tool to patients who are low risk and medium risk? And George, if we could go on to the next slide. This is just a slide to sort of give you a sense of what SelfBack is. I know you'll all be aware of digital apps that support self-management, and this is one that has a randomized controlled trial behind it. And there's a plan to roll that out now within our particular region, and they needed to start to do an evaluation of that. And next slide, just to show you that what we were able to do is compare against the MIDAS sample that we have in general practice. What was the patient experience like of patients compared to MIDAS sample who went through the self-management process? What was the difference in terms of the sorts of characteristics of patients who took up the app compared to others who we have in our MIDAS sample? What were their clinical outcomes, and what were the differences in treatment patterns that patients received? And lastly, clearly they were able to look at a more detailed qualitative analysis and interviewing patients and clinicians about their experiences. So just as a sense of the direction in which this has been able to go, and I have to say, I don't want to give the results because I'm stealing someone else's research by doing that, but I think it just shows the importance, because I can say that it's gone on to the ICS saying, yes, we do want to commission that SelfBack app and take that further and roll it out in A&E and in GP practices and community services. So it just shows the importance of this kind of data once we have it. Thanks, George. I'm going to stop there and hand back to you. Just last thing to say, though, is a big thank you to the BSR, who have been funding the National MSK audit up to now, which is huge. We're hugely grateful. Thanks, George.
We've probably used as much of our time as we should. So I guess just to note those very sort of quick high-level points of learning. So around generating tools, and that's fine, but I guess I'm still struggling a little bit to work out where's the best way to make those discoverable and in sort of one place. We've gone through, like many of us, I suspect, a number of sort of blind alleys for data access and linkage and things are sort of gravitating towards the secure data environments, but we're still learning about what the sort of pros and cons are of those routes. We've underestimated, I think, the sheer level of resource around data management and analytic capacity. So I think there are also issues, I think, about academia partnering with analysts in local authorities and in the NHS about how we better develop those skills. Communicating for impact. That one map that I showed you about the LSOAs has stimulated more discussion and opened more doors than anything else that we've produced. There's something about data visualization that's really critical here. And at the heart of it is still my sort of slightly sort of Presbyterian approach to, well, yeah, but there's bias and there's uncertainty and there's issues of transportability. I think how one communicates that without completely chilling the sort of momentum around these things is still a bit of a challenge. Thank you.
Thank you very much to George and Jonathan. I know it's difficult presenting online for those who have Celia and Jonathan, so thank you very much. Fortunately, not very many technical difficulties today. So I'm going to open up for questions now. We've got a reasonable amount of time for questions for people. So if you've got anything on the last presentations, please. Forget again, I've got the
I guess this is a question to all the speakers. When we're focusing on a disease such as rheumatoid arthritis, we believe we have a start date. We know when the diseases start in terms of audit. We have the ideal practices in the early phase of disease. In chronic musculoskeletal pain, we're dealing with a lifelong career of pain, and often work done in Manchester by John Mother's years ago shows that actually it often starts in childhood. So what are the challenges, I guess, particularly in audit, but also understanding both the appropriate services for pain, given the fact that people are going to come to it through a career with a previous experience of access to services, failures, etc. I mean, it's a challenge, isn't it?
I was sitting in the wrong seat, wasn't I? Yes. So I absolutely agree, and I don't think you can actually pin down any sort of start date to these things, certainly not through the routinely available data. I think you can certainly have a go at trying to understand episodes of care and that sort of cycle, although again, one has to be mindful of trying to understand, well, where in the overall sort of timeline is that episode of care coming. I don't think it's unique to observational data, though. I would say the same criticisms there for clinical trials. How do you know who you're dealing with in these things? And people will be well in different ways. I guess one of the ways is to use self-report, try and get at what people are able to tell you. Again, that's slightly slippery, but at least it provides some information that might not be accessible in the record. The other is the importance of having longitudinal access to records, so one is needing to see these things in very long time frames, and that has been a challenge, I think, in the availability of some of those data, although it is improving over time.
Just to follow up, I mean, I think you're right to think about episodes, and they're not always easy to decide when a person is within an episode and when a new episode starts, but I guess we need to have some rules that can apply to what constitutes a new episode.
And I think people have tried to apply some sort of a, like a washout period almost, where you say that no consultation within the previous year, and then we'll start calling this a new episode. I think there has been in the past been the facility to indicate a new episode of care actually as an entered field in the primary care record, but that I think has never been sort of well completed, so one wouldn't rely on that. So I think those sort of rules about a washout period, again, not perfect, but at least it's something, I think, to try and get a bit more consistency.
Mark, did you want to comment anything about pain aspects of that, given, in the terms of the difficulties of how you're studying and understanding when something may have started?
Thank you. It's difficult, isn't it? You've raised a real issue. And one of the things in our research that we have done is you saw those blue graphs, the bar chart of all the prevalence of long-term conditions. Actually, that wasn't adjusted. None of those conditions were adjusted with the addition of remission resolve codes. So an awful lot, particularly the estimates of asthma and epilepsy, are too high because researchers haven't applied remission resolve codes. We're not here to discuss asthma and epilepsy. What happens if you apply those to chronic pain? What would be the criteria? All I can say is that chronic pain so often seems to be a relapsing, even if a lifelong condition, and perhaps we ought to be looking at the same process of remission resolve codes. We have a paper on remission resolve codes and what it does to prevalence, and perhaps I can just pop that through to you later.
Thanks, Mark. We do have a question or two online, Michael.
Yeah, we have quite a few questions. We can pose a couple of questions to Mark. First of all, lots of comments about the presentation. I enjoyed the presentation. I'll speak a little bit louder. The first question is on that chronic pain doesn't quite get the limelight of some of the other chronic pain conditions, and we wondered what we could do to increase the profile of chronic pain. And the second question is question/comment is that it would be great to see further outcomes/evaluations on your project and how it could be an exemplar of how others could approach their work in their area.
Yeah, I think you are spot on in saying that. It needs its profile raised. I was dead surprised that BBC London pounced on that finding, but that's because we had a really sky-high finding. Remember, the baseline prevalence in our sample was 17%. Certainly isn't 17% in Black Caribbean ethnicity women. That was the 54% figure, and that was sufficiently big and different to be headline catching. But I think the real work is on the ground, and I think we need to look very carefully at what is happening in Stockwell Primary Care Network, and have social prescribers really got such a big role in supporting patients with chronic pain and also supporting primary care for those patients with chronic pain. And I say that thinking of our own burden, bit selfish, sorry, but we are overwhelmed with consultations. And if consultation rates can be reduced through something that's more creative in its approach to chronic pain, well, surely that's a win-win situation.
Are the bottom line?
Thank you. It was more a comment, and just to say that we're doing a programme of work called PackFind, which is funded by Versus Arthritis, and that's a 5-year programme grant, which is looking at how we can design and deliver better care for people with fibromyalgia. And as part of that, we've looked at fibromyalgia within Wales, within the SAIL cohort, and identified over 20,000 patients and looked at their patterns of healthcare use. And before index date, and over half of them have been referred to general surgery, orthopedics, gynecology, neurology, pain, and we compared them to controls and significantly more invasive diagnostic procedures as well. And I think that also ties in with the survey and the qualitative work we've done, which general practice feel very unsupported, challenges in being supported to make the diagnosis, and I guess that the difficulties of people presenting with lots of symptoms and they end up with lots of investigations and which may or may not be appropriate and potential for harm. So it's just about sort of, there's a huge burden within the system.
Mark, at the end of your presentation, you told us how the social prescribing that was done in Stockwell had really positive results and was therefore rolled out to Lambeth. Could you tell us a bit more about the results? What did it show, and how was it measured? Because social prescribing is the sort of thing that isn't commonly held in the health record. How do you know what the outcome was? So just tell us a bit more about what was needed to influence the rollout and what evidence you generated to support that.
Good question, because we need to know how generalisable these findings are. Something good is happening around Stockwell Tube Station on the Northern Line, but is it generalisable? It hasn't yet been rolled out in Lambeth. That's the proposal. And we are keeping NHS England closely involved. They are interested in using, I find myself sitting next to Katie Yeo, who I hadn't realised from outcomes-based healthcare, they're going to be using that very algorithm. They've been told all about it. But in practice, what does a social prescriber do? And in this particular pilot, they did something called a holistic health assessment. And the holistic health assessment was very much looking at the medical, psychological and social aspects of pain. Word on the street was that the social aspects came out very strongly and were largely ignored by general practice. So it was great for patients to think that the social agenda had been addressed in a way that primary care wasn't addressing it. You also asked about monitoring. The monitoring was the monitoring of GP consultation rates, and particularly the social prescriber role. I mentioned following NICE guidelines, but it looked like it morphed into something like a life coach by the end of it all. and people are offered life coaching sessions. And that's as far as I know. And I don't know, Katie, you don't know anything about this pilot in Stockwell? No.
So no results yet from the evaluation?
No, and it needs to be all written up, and that's coming.
Questions online?
Yeah, we have a question for John as to whether the increase in prevalence is a genuine increase in the prevalence of disease, or whether it could be down to improved coding.
Thanks. It's a great question. So I think it's a combination of many things. I think it's a combination of changes in coding, changes in awareness, and then consultation to primary care, and often on referral to secondary care. I think that if you look at the fibromyalgia data, for example, it's really interesting that, before we introduced sort of formal coding schedules for fibromyalgia and read codes, the sort of prevalence was still quite high. But when you look at other codes, so I think that's the one of the things to do here is to look around for those changes in coding practice and see what was going on before that, and try and capture that data. I think that will give you a better insight into the prevalence and incidence over time. But of course, all of those other factors are going to influence it, and that overlays above, probably a true increase over time. So one of the studies that Alan and I did a long time ago was looking at change over time in population data, so not relying on consultation to primary care and coding. And there was a change over time. So over a 40-year period, the prevalence of fibromyalgia, a sort of widespread pain disorder, had increased by, I think, about overall twofold, but it was significantly greater when we looked at women compared to men. So I think, bringing all those sources together really helps you to understand what's going on, without being able to directly measure and assess, awareness, GP awareness, patient awareness, those kind of issues.
Anything else, Michael?
Yeah, we have another question in chat for George and Jonathan. It's a bit more of a broader question. Michael.
Yeah.
Sorry, a question for George and Jonathan. A more general question on your thoughts on digital exclusion. As population health management would imply that there are many without digital devices.
I can go first and Jonathan can come in. Yeah, I think, so it was interesting in the context of doing our studies. We tried to resist actually using digital data collection methods at the first. It was probably the only way, though, of efficiently collecting data through the general practice cohort study that we described there. And actually, we did offer offline data collection, as I suggested. There were exceptionally few people that took advantage of that. So I'm not sure if we've learned much about how digitally excluded people might engage with some sort of data collection at the point of care. There's very high numbers, though, for example, registered with even just a mobile phone or device with practices now. So I suspect that there's still quite high coverage, but we're concerned about those that aren't able to take part. The population survey was done all offline. It was conventional mailed stuff. So actually, and we made that decision. It was certainly more expensive to do that. We offered an online option, but because we were concerned just about that issue of digital exclusion. So yeah, I think it's a real issue, and it probably also has some implications for self-start and those sort of digital interventions as well. But Jonathan can pick that one up.
Thanks, George. And just to add to that, I think one of the analyses that we're planning is to just look at what's the impact when you compare people who have used the online route versus those that haven't, and we've got that data, so we can look. We need to look and see, is that giving us a particular selection bias, or what's the impact of those different routes, and that's one of the things on our to-do list. But thank you for raising the question, Sarah.
That's brilliant. Thanks, Jonathan.
If you have no other questions in the room, I think the last question is more of a general question for each of the speakers. So there's been lots of chat about population health management in the online chats, and I wondered if each of the speakers could just say a little bit more about that and how they see their work contributing to population health management.
Celia, are you okay to answer that one? We've still got Celia with us? No, Celia's gone. In that case, we'll start in the room. Will, can I start with you?
So it's for the
It's for everyone.
It's not for the afternoons. For the afternoon.
Late morning panel. Right. Can we start with you, George?
Oh, thank you.
Thank you.
So yes, I mean, so my sense from our program of research is that we see, the importance of primary care and, increasingly a sort of wider team within primary care being critical still to the management of these common musculoskeletal health conditions. But I suspect, given the sort of population patterns that you're seeing there, the fact that it looks as though people are following a bit of a common trajectory, but not shifting much from the sort of mean distribution that they're coming from in their sort of population, that still a lot of the answers to this are held actually outside of the healthcare system. And I think public health and longer term strategies are still, the sort of key, I think, to shifting some of the stuff that we're seeing.
So I suppose it's two things really. The data that we've provided from CPRD and others have provided, with all its caveats, is important because it allows us to try and understand how common these conditions are. I think the modelling that we've done in Manchester is really important because it allows us to estimate that at these lower level geographies as I presented, and that just hasn't been available to any sort of, I think, sufficiently high standard before. So that's an opportunity, and that sort of feeds into conversations around workforce planning and other conversations. I agree with George. I think a lot of what we're seeing, if we think about musculoskeletal pain conditions, is primary care data and the coded data in CPRD is great, but we know from previous work that we've done at Manchester over time that people come in and out of primary care for lots of different reasons, not just related to the musculoskeletal condition. And so to really identify, target those people and to put in place appropriate management strategies, you need to try and look outside into the population.
John, thanks. Did you want to come in?
Yeah, just an additional comment on the topic. I mean, I think the thing that I'm just keen to raise is about the digital data and the digital infrastructure that is emerging to support this. And I mentioned the subnational SDE program, but I think it's worth it just expanding on that a little bit. So in regions of the country, there is investment and the ICBs are expected to look after their data such that they can support population health and research. In Greater Manchester, this is a partnership between the Greater Manchester Health and Social Care Partnership, Health Innovation Manchester, and the University of Manchester. And together, they're looking to look after the region's health data for three purposes. So firstly, for direct care. And so the Greater Manchester Care Record is connecting primary care electronic health records, data from hospitals and data from other data sources, so that if you're in my clinic in Salford, you can see primary care data from somebody whose GP is in Oldham. And that's up and running and working very well. The next layer is that data is looked after in a secure environment for population health and planning purposes. And so the Integrated Care Board is interested in what does it have to do to look after the population of its region. And in Greater Manchester, they're running at a significant funding deficit at the moment. They've projected that looking forwards, and it gets much bigger because of changing demographics, increasing long-term conditions, lots of other stresses on the system. So they want to know what can they do to offset and prevent that from just continuing to grow. And then the third layer is that data is then shared within a secure data environment for researchers to be able to access, but that same data source. So, the investment in regional infrastructure, where the custodian of that are the integrated care boards, I think is really exciting, and it will be a massive opportunity for all of us to make a difference here, either through population health analysis and planning or via research. But joining to the dots of several of the presentations this morning, a really important thing is about the data foundation for that, be it from primary care or secondary care, and we should collectively be trying to, from the academic community, help us understand that and make a difference and improve that for the future.
You will. That's really important. Some really important things to think about. I think I'm just going to ask Mark to answer that question, the original question.
I think the first task is to make chronic pain visible. And all I can say is, I hope I've made it visible to you today with that 54% headline. We've certainly made it visible to our GP colleagues who frankly had no idea. So please get out there and give the message to primary care. My second response is a bit more political, and that is that we look enviously at the GP contract north of the border in Scotland, because they've all got allocated a physiotherapist, a pharmacist and a psychologist. And quite frankly, all three of those professions can probably contribute substantially to the management of chronic pain. We're edging towards that with our primary care networks. They can choose what sort of healthcare professionals they employ. Many do employ pharmacist, physiotherapist, psychologist, but social prescribers seem to be the main body of professionals that they're employing. And I hope my presentation showed you that I believe they really do have a role in the management of primary care, of chronic pain patients in primary care, particularly with their medical, psychological, social type agenda. Thank you.
Thanks very much, Alan.
The question was on population health, and I'd echo with both John was saying in relation to those people who never come to primary care. It was the case, and it may still be the case, that only 1 in 5 people with an episode of back pain will seek help from their general practitioner, and I suspect that's true for many other painful conditions. There's an encouragement within the community for self-care, to have a greater role for pharmacists, for direct access to physiotherapists. And of course, what we don't know is whether those people who do self-care are actually achieving better or worse outcomes. And so I think maybe the challenge, maybe throw that to Will, the challenge is how in the data environment we can begin to capture some of what happens outside current primary care and the other solicitors. I guess thinking what's happened in Wales, where people don't have geographical access or don't get on the telephone at 8 o'clock to make the appointment for their GP.
Good question. Maybe we could continue answering that afterwards, unless, Will, you've got something very rapidly that you'd like to contribute, because we are coming to the end of our time.
I just want to ask Jonathan if he wants to add.
Yes, of course, Jonathan, if you want to come in.
Oh, thank you. I'll be quick. I just want to echo what others have said. I completely agree. And I think this data invisibility is what I really feel we need to sort out. ICSs, I sit on an MSK transformation board, do not have the data at their fingertips, particularly for the primary and community care piece. And I think there's a real pressing need for us to provide the tools that they need so that they can see where is the big levelling up piece required, and then do the piece of integration truly between what the local council is providing and what the health service is providing to try and address that. And at the moment I just don't see that they really know where, particularly for musculoskeletal problems, they need to be doing things. And I hope that we can try and address that as a group and solve that problem for them.
Thank you very much, Jonathan. I think that's good place for us to end. I'd like everybody to put their hands together once again, please, for all of our speakers for this morning, because they've been fantastic. And I think, given that I've been talking since 9:30 this morning, you've had enough of me. So I'm not going to wrap up and close this meeting. I'm going to hand over to Benjamin Ellis, who's going to do that for me. So thank you very much, Benjamin.
Thanks so much, and thank you to everybody who's presented today, asked questions, for a whole group of people who have helped enormously. I won't name everybody in the health intelligence team, but who's put stuff together, not just the contents of the meeting, but made sure that tea and coffee and food are in the right places, and there is some more right after this, and to make sure we all know how to escape in the event of a fire. As always, just a brilliant meeting, and loads has been going on in the chat, quite a bit with me, but it's prodding people. And it's always extraordinary to me what emerges from a conversation which begins with data. And in fact, we're talking about policy, we're talking about clinical practice, we're talking about wider practice, population health management, we're talking about resource allocation. It struck me there's a framework of what data can do. And I think when Alan and I set up this meeting in 1832 under the Empire, what was it called? Something else. But we had a sort of set of thoughts, but we couldn't have known how extraordinary this group would become, not just the individual context, but the connections and the relationships that emerge from this meeting, the collaborations and the ideas as well. And data sort of begins sometimes as academic curiosity. That's step one. We just want to understand what's out there. What does it look like? How much of what is where? And it's very descriptive. And we move from that to thinking, okay, well, then sort of next step up from that is resource allocation. What we need to do is, well, if chronic pain is this much, and if arthritis is this much, then that much of money or that much of time or that much of people should go towards that. But then we start to build on that. And we're talking about visibility and profile, that it's not just enough to give things resources and money and time, but we actually need people to care. Then maybe that comes the other way around as well. Maybe you need both of those, but then you get visibility, you get profile of things which tacitly every general practitioner knows, that your duty list is full of people with chronic pain, but to actually see the figures and gosh, how much of the impact and the work from that you're doing with outcomes-based health show that persistent attendance in primary care, 50% was driven by chronic pain, which is extraordinary. And then we move on, like we had today, we had presentations about variation. So actually not just, we've gone beyond visibility and resources to say, well, where are things going well, looking at outcomes, where's it going well, where's it going badly? And could we put more effort into supporting people who are doing badly to do better, rather than simply rewarding people who are already doing well with additional resources? And then we start to think, well, we're looking not just at variability of places, of institutions, but variability between different populations. Are there certain included populations? We've heard about certain minority ethnic groups, geographical variation, how far away you live. So we start to look at variation. We can't change how far away you live necessarily, but we can start to think about how we tackle that variation and we understand it. And then we start to think about population health management and the role of data in identifying individuals, not just populations, but are you or a person who might be in particular difficulty, and actually we could do our population health management, inviting you up for additional support. And we've heard about some of the other roles that can offer that support. And then all of this ultimately, then the question is, none of this really matters to people with arthritis, chronic pain, musculoskeletal problems, unless there is action. And that's one of the things which has again come out of the conversations of this group. And we always imagined or wanted this group to be a forum for action, and that there might be, and that subgroups of people within this group, either formally or informally, thinking and reporting back on, well, how does some of this, we've heard about people working with NHS England or NHS in other of the UK nations, how do we then bring together the thinking we're doing and the problems we have begun to solve and the variation, all this, how do we then turn that into action? And that is an ongoing conversation about how this group can do more. So thank you so much. Thanks to everybody. And I think it's lunch. And if you're at home, you can also have lunch, but I'm afraid we can send you pictures of lunch, but you're missing out on the lunch here. So thanks so much. And Michael, is there anything else from you?
Evaluation. Feedback. Please give us feedback. So we'll put something in the chat. If you're here physically, there's feedback forms, I think, attached to the programs. So please do give us feedback. If you've got ideas, colleagues that could present next time, please let us know as well. And otherwise, just thank you so much for being here and lending us your time and brilliance.
Thank you all.